الو.
مساء الفل يا دكتور حسن. دكتور حسن بيه،
دكتور محمود باشا.
ازيك حبيبي؟ عامل ايه؟
حلو
باشا انا قاعد دلوقتي في الصومعه بتاعت ادهم بيه مهران، اللي هي فيها كميه تكنولوجي وكمبيوترز وحاجات. انا قدامي شاشه يا دكتور حسن، مش عايز اقول لك عامله زي شاشه السينما كده. والواد مظبطني تظبيطه غريبه جدا مطرح ما هو بيلعب بلاي ستيشن.
ده بلاي. انا كنت اقول لك هو في كليه ايه.
لا ده لسه يا باشا، لسه اخر سنه السنه دي.
ربنا يقوي يا رب. هيخش فين؟
هيخش بقى الحاجات بتاعت الانجينيرينج والاي اي والسايبر سيكيورتي والحاجات
هيخش
الجديده
هنا
دي.
ولا هيسافر؟
لا هيخش هنا يا بيه ان شاء الله.
ليه يا عم؟ لا لا لا.
عشان امه، عشان ابن امه مش راضيه تخليه يسافر.
ده اقناع انه يسافر احسن
و...
ويرجع.
وانا عبد المأمور يا باشا، انا عبد المأمور.
خير.
مساء
خير
الفل.
يا باشا. هو حضرتك هتبدأ اول توك يا دكتور حسن؟
مش عارف.
لسه.
مساء الفل.
مساء
محمد
الفل
باشا.
يا حسني باشا.
اخباركم ايه؟
ازيك يا حبيبي؟
سامعك بتتكلم في السياسه.
انا لا، انا ما
اه،
اقدرش يا باشا.
سامعك بتتكلم في السياسه.
انا ما اقدرش يا باشا.
اخباركم ايه؟ رمضان كريم.
الله
مساء
اكرم يا
الفل
حبيب
جمال
قلبي.
بيه. يا محمد.
صباح الفل يا باشا. مساء
ازيك يا بيه؟
الفل.
أهلا.
زي
دكتور
سعاده
جمال
الاخبار
باشا.
ايه؟
أخباركم إيه؟
زي
الحمد
الحمد
لله.
لله. كله تمام الحمد لله.
دكتور الأشهب فين؟
دكتور اسامه بيه.
دكتور اسامه بيه صباح الفل.
دكتور اسامه بيه، كل سنه وحضرتك طيب.
يا حسن.
ازيك يا بيه؟
إزيك عامل إيه؟
الحمد لله. ازي سعادتك يا بيه؟
شكلك فطرت فعلا يعني كويس.
الحقيقه يا بيه
دكتور اسامه سمعنا؟
الظاهر عامل ميوت ولا إيه؟
مش سامعنا تقريبا.
لسه بيفطر يا دكتور أسامة الظاهر.
كوبايه الشاي يا باشا، كوبايه فنجان القهوه.
حسن أنت ما رحتش الأمريكان أكاديمي مش رايح؟
شكلي بيه هزوغ. هم عمالين يبعتوا لي الديسك ومش الديسك ربنا يسهل يا بيه.
شد حيلك يا حسن شوية، ربنا
والله
يسهل. إيه
والله
أنت
بيه.
مسافر بعد كام
لسه
ساعة؟
لسه ما حجزتش. لسه
لا
ما
انا
حجزتش
انا مجهز كل حاجه
يا راجل.
ما عدا تذكرة الطيارة.
ما عدا تذكره الطياره والقرار.
يا ولد.
يعني والله بيه هنا عمالين يسربوني يقولوا لي سافر سافر، بس انا الصراحه بيه رمضان يا بيه صعب قوي.
ما هو أنت هتفطر هناك، ما أنا هجيب لك الفتوى.
يا بيه مش على الفطار يا بيه، فكره 4 أو 5 ايام ونرجع دي
السلام
صعب.
عليكم.
سلام
وعليكم
يا
ورحمة
ورحمة
الله
كاتب.
الله
وبركاته.
وبركاته.
أهلا افتخار، إزيك؟
الله يسلمك، الحمد لله. هلا دكتور، كيف
عامل إيه؟
حالكم؟
وحشني.
طيبين؟ الله يعطيك العافية. ما
رمضان
شاء الله
كريم.
يلوكون.
فطرت ولا لسه افتخار؟
منى.
ها.
فطرت
ايوه.
ولا لسه؟
اي لا لا، فطرنا الحين عندي 8.
انتوا متأخر عننا
لا
7.
قصدي 9.
9 دلوقتي
اي 9، فالحمد لله. بارك عليكم شهر رمضان كلكم.
الله
عليك
يخليك يا
عليك
افتخار، ازيك يا
يسلمك.
حبيبي؟
جميعا.
الله يحييك ان شاء الله.
يا حسن انا عايزك تسافر، وانا جبت لك فتوى تفطر اسبوع كامل مش 4 ايام بس. ايه رأيك؟
طب انا لو افطر رمضان كله يبقى تستاهل.
دكتور محمد اهو، دكتور محمد لاشل اهو.
السلام عليكم دكتور جمال.
يا دكتور محمد ازيك؟
معلش لسه صلينا العشاء بس وجيت جري.
انا عمال اجيب لهم فتاوي عشان نفطر في رمضان وحاجات كتيره، خلي بالك يعني.
لا انا الحمد لله انا اصلا مش رايح امريكان اكاديمي. مش هقدر. رئيس الجامعه مش راضي، قال لي انت عندك شغل في الكليه.
عيب الإدارة بقى، عيب الإدارة دكتور محمد، ربنا يعينك.
والله يا دكتور محمد بيه
عيب
قال لي انت
الإدارة
عندك
ربنا
شغل كتير في
يعينك.
الكليه، مش هينفع تسافر الامريكان اكاديمي.
لا
يا
اه
سيدي يديك يرضيك. لا
ربنا يعينك.
بصراحه السفر في رمضان صعب يا دكتور محمد بيه.
لوجيك طبعا.
انا
طبعا.
جربت مره، فاكر حضرتك مره في اليابان يا دكتور جمال؟ في
اه
الاسامي ما كنا في ماليزيا واليابان.
فاكرها، بس انا برضو فطرت مفيش مشاكل.
لا انا ما بفطرش انا ما بفطرش
لا
بتعذب يعني.
انا ما بفطرش برضه، بس بيبقى عذاب فعلا.
لا يا
لا
حبيبي،
بتعذب.
احنا بناخد كل الرخص في
انا
كل
انا انا
الكل
مش
السلام
عارف
عكس
احنا
عليكم.
ليه بنعمل
تماما.
ليه بنعمل في نفسنا كده؟
مش عارف
على
والله.
سفر
مش
على
عارف
سفر
والله.
نفطر.
لا مش عارف والله، هي برضه بتبقى يعني الحقيقة تصغير مخ احيانا.
اه فعلا بتبقى قفشه غريبه. انا ما بفطرش برضو، بس بقعد
دكتور
اقول ايه
محمود
ايه
ازيك
اللي
يا
انا
حبيبي؟
بعمله ده.
ايوه بالظبط.
ازاي حضرتك دكتور محمود بيه؟
ازيك يا حبيب
السلام
قلبي، اخبارك
عليكم،
ايه؟
ازيك يا
وعليكم
ريس؟
تسمعوني؟
السلام ورحمة الله
سلام ورحمه الله
وبركاته.
وبركاته.
بركات.
لاس ازيك؟
زي الصحة،
عامل
أخباركم؟
ايه؟
الحمد لله والشكر. ازيكم؟
ايه اخبارك؟
ازيكم
ازي
على
حضرتك يا
رمضان؟
فندم؟
انا جاي بغداد يوم 11
أهلا وسهلا.
11
ليش ما تيجي
ابريل.
لأربيل؟
هو اربيل دي صعب الواحد يروح
لا مش صعبة والله.
والله.
أنت قول لي وأنا
في
أرتبها.
مؤتمر عاملينه من 11 ل 13 وعازمني في بغداد.
مؤتمر إيه؟
ما الجمعيه اتحلت، عاملين جمعيه جديده.
أعرف، أنا أعرف.
اه
بدي أنتظر منهم من بنا، ست بنا اللي هي
اه
سكرتيرة، إنه هم يتصلوا فيها. اتصلوا فيها لو حنتصل بيك، باعتبار أنا أعتبر مثل الجمعية في كردستان.
اه.
بس لسه ما شفتش أي تليفون من بنا، ما أعرفش ليه.
ما اعرفش، غريب، انا مش عارف.
أنا عضو في الجمعية العراقية لجراحة عظام والكسور من عام 1993، يعني 32 سنة.
يعني انت اصغر مني ب 30 سنه، مش كده يا راس؟
تمام تمام. فأنا يعني بالجمعية من فترة طويلة، بس المشكلة كالعادة إنه في صراعات سياسية دخلت، والصغار بدهم يطلعوا الكبار. يعني
اه
أنا يعجبني في مصر من جهة المؤتمر 2021، من شفت الوزير ولا النقيب ولا وكيل الوزير ولا حضرتك، كلهم ناس كمل وكبار ما شاء الله. انت هنا بيجيب واحد عمره 26 سنه بيعمل نقيب الاطباء، من طرف جهه سياسي. مش ممكن، يعني مش ممكن. فنفس المشكله صارت في بغداد، يعني طلعوا مثلا وليد الدوري، مثلا زيد الشهواني، الناس الكبار يعني اللي يشتغلوا في الجمعيه دي من فتره طويله يعني.
هو
ليث بن
المشكله
فياض.
ان الطرفين حبايبي، يعني خلي بالك يا راس، هي دي الفكرة.
لا المشكله شنو؟ انه هم ممكن انه يعني،
الصغيرين حبايبي والكبار حبايبي الاثنين.
لا مش مشكله مع الصغيرين، بس الاسلوب ده اللي موجود في كل العراق. يعني تلقي هنا في مثلا من زاخو الى الفاو، انه هذا الجيل جيل غريب شوي يعني. ما عندناش في كبار وصغار بقى، يعني مع الاسف يعني انا قلت لهم خلينا نعمل انتخابات ونختار، بس لازم الكبار الاهل الخبره يبقون، يعني لازم اهل الخبره يبقون.
هو كل واحد بيعرض بضاعته، يعني كل واحد بيرمي التعبان بتاعه، وهي دي المنافسه. كبير صغير، عنده 18 سنه،
لا احنا
عنده
ما فيش
120 سنه، مش مهم.
ما فيش لا هي ما فيش صراع، هي مش صراع. المشكله انه هم بيسمونا ديناصورات.
اه.
الكبار في العمر يعني.
ما يمكن عشان البرايفت اللي انت بتاخده منهم يا لاس برضه، ما هو دي
لا
ممكن جدا، أنا مش عارف.
هم حاليا بيشتغلوا
آه.
اكثر من عندنا باساليب خاصه. يعني مثلا اذا انت طلبت من عمليه فرضا خلي
آه.
$1000، يروح
آه.
عند الشباب قلت تعال اعمل لك اياه $200، حتى لو ما ياخذش مليم. اهم شيء انه انت ما بتشتغلش.
شوف يا
يعني
لاس، احنا اخر حاجه تهمنا الفلوس، فهمت قصدي؟ بس
انت
دي نقطه.
فهم الفكره مش الفلوس.
وبعدين احنا ما فيش منافسه، يعني هم ياخدوا الحالات البابليك وانا اخد البرايفت، فما فيش منافسه. الصراحه يبقى فيه.
لا هم ياخذوا
مفيش
الحاجات
صراحه.
الببليك، ياخذوا الببليك والبرايفت. على كل الفكره انه انا كان عاجبني يكون مجموعه من الكبار قدماء كخبره لاداره، مش كلها صراعات ومنافسات وحديه التنافس يعني. ما مش كويسه يعني.
احنا بنحطها ان شاء الله في الاتجاه الصحيح، يعني اللي هو
امين.
التنافس في
والله
الفهم
انا بدي
والعلم، يعني
انتظر
فهمت قصدي؟ ده حميد.
تليفون من بنا، هي سكرتيرة الجمعية، لأنه سنتين ظلت الجمعية ما فيش جمعية، سنتين تقريبا
مم.
من الصراع
ما
والمنافسة.
عملوش هم ميتنج يا استاذ.
تم حل الجمعية بقرار من الوزير يعني. حاجة
مم.
غريبة يعني الجمعية انحلت
خلاص.
بقرار من الوزير،
خلاص.
ازاي ما اعرفش.
خلاص احنا هنضمكم معانا وخلاص بقى.
احنا ممنونين
بس
والله،
بقى خلاص احنا اخوات يعني.
نكون مشكورين يعني. لا ان شاء الله بس المره دي حتكون كويسه
ان شاء الله.
ان شاء الله. ان شاء الله.
الاساتذه الزملاء العرب وصل لهم اللينك كلهم يا دكتور جمال بيه ولا في
كله
حد؟
وصل. بص كله وصل.
كله وصل. تمام. يعني we have just 2 minutes to start.
ان شاء الله ان شاء الله. دكتور اسامه موجود ولا فين؟
معاك
دكتور اسامه
كمان.
موجود.
ازيك دكتور
اسامه بيه،
اسامه؟
كل سنه وحضرتك طيب يا
مساء
استاذنا.
الفل.
مساء طيبين.
حضرتك الصحه
ألف
والسلامه يا استاذ.
سلامة.
دكتور محمد ازيك؟
استاذنا كل سنه وحضرتك طيب يا استاذنا.
كل سنه وانتم طيبين وبخير
ربنا
دايما
يدي
ان شاء
لحضرتك
الله.
الصحه
كل
وطول
سنه
العمر يا
وانت
استاذ.
طيب.
الله يخليك.
دكتور لاس من كردستان، والدكتور افتخار من البحرين، دكتور اسامه
مرحبا.
حجازي استاذنا.
اهلا
مرحبا.
بحضراتكم.
اهلا وسهلا.
اهلا وسهلا.
احنا ان شاء الله
دكتور حسن الدبري معانا كمان يا فندم.
برد على ستار.
منور يا
يا
فندم.
ستار، سلام حكايه، ازيك يا حبيبي، عامل ايه؟
دكتور مينا،
دكتور مايكل.
انا عايز اعرف بس، هو احنا
غريبه قوي.
كل اللي معانا هيبقوا عرب من الميدل ايست؟
كلهم يعني
طب
هو
ماشي،
احنا
هكلم
بشتغل
بتاع
على كل حته، ففي بيوت بيبقوا موجودين
التكنيكال
وباكستان ويعني بس مين
يعني
ليه عربي؟
نتكلم بالانجليزي ولا ممكن فرانكو اراب
فرانكو عربي يا
براحتنا؟
فندم. فرانكو عربي.
فرانكو اراب.
لا مش فرانكو عربي، احنا ما نعرفش فرنسي.
فرانكو اراب يعني
إنجليزي.
ايه؟ بنت
إنجليزي.
علاء ده عندنا.
يعني
انجلو عرب كويسه، هنفهمها
انجلو
كويس.
اراب.
حتى اذا مصري احنا ثقافتنا بالعراق تقريبا مصريه، يعني
أيوة.
من القصص والمسلسلات والافلام وكده، فاحنا
أيوة.
نعرف نتكلم مصري كويس.
العراق ومصر حاجه ثانيه، حاجه واحده طول عمرهم يا فندم. طول عمرهم حاجه واحده يا فندم.
لا بالانجليزي احسن يا لاس.
انت براحتك. افتخار، انت شو تقول؟ احنا حاضرين. هو لا، اللغه هي انجليزيه، مش يعني مو عربيه. بالانجليزي، لانه تعابير ومصطلحات نستخدمها. شلونك افتخار حبيبي؟ اخبارك؟ افتخار، شلونك افتخار؟ هذا يسمع.
يسلمك، الحمد لله، بارك عليك شهر رمضان يا اخي.
بارك على الجميع.
دكتور جمال we are ready to start يا فندم.
ثانيه واحده.
اوكي.
هو ستار بيخش، بس ستار حاول يخش غالبا من اللينك التاني.
احنا بعتنا له لينك اوريدي تاني يا فندم.
هو غالبا هو غالبا دخل من اللينك بتاع الاتنديز، لان بيقولوا انه سمعنا بس مش عارف يخش. سمعنا
دكتور مايكل ممكن نحوله من اتنديز لباناليست يا دكتور مايكل. دكتور مايكل. اتكلم بس دكتور مايكل.
مع حضرتك.
نحوله دكتور ستار، نحوله من
دخل غلط
لباناليست.
اوكي شور.
الحضور هايل حبيبي، كويس قوي.
والدكتور محمد قناوي نفس الحكايه، الظاهر وصلوا باللينك بتاع الاتنديز.
ممكن نبعت لهم لينك تاني يا دكتور جمال، مفيش مشكله.
ابعتوا لهم، ماشي، ابعت لهم يا امين.
دكتور مايكل نبعت لهم لينك تاني.
تمام يا دكتور، اوكي. هو اوريدي لينك الباناليست انا بعته له تاني، والمفروض ان انا هو هي ديكلايند البروموشن تو باناليست، يعني هو انا محتاجه بس يابروف. دكتور ستار
بعت
بليز.
له اهو.
اوكي.
دكتور مينا، استاذن حضرتك لو تبعت لنا برضو اللينك بتاع الاتنديز.
شور يا دكتور.
طيب استاذن حضرتك لو تقدر حضرتك تبعته لي على الموبايل على طول اسهل.
هبعته لحضرتك دكتور حسن، هبعته
على الموبايل لو ممكن يبقى، معلش.
حالا يا فندم. عادي.
شكرا.
صالح ده
يا
يسأل
ستار.
صالح ده يسأل صالح يريد
اوكي
اللينك.
ماشي، هنبتدي على طول. اوكي
اوكي دكتور ستار معانا باناليست.
ستار دخل خلاص.
بعته لحضرتك دكتور حسن.
شكرا ليك.
ستار دخل خلاص.
يلا. السلام عليكم اخواني.
سلام كيف؟
السلام طيب
يا
بركاته.
ستار ازيك؟
الو عين ستار، مرحبا حبيبي.
الله يخليكم. Lovely meeting you guys.
ستار انا رايح بغداد يوم 11 الشهر الجاي، مش عايز تيجي ولا ايه؟
آه
انا بروح اكتر منك بكتير، خلي بالك.
والله. Is it for the Iraqi association meeting?
الجمعيه الجديده.
Yeah. I forgot his name. He sent me invitation.
فريد اسمه.
المشكلة أنا يوم 20 مسافر على بريطانيا لمدة أسبوعين.
عشان كده.
Yeah. فإنه week after the week is gonna be tough. I haven't said no, but I haven't said yes yet. إذا أنت رايح والله شجعني إنه ممكن إنه راح أجي.
انا بشجعك اهو، يلا.
أوكي. أنت 3 أيام الويكند رايح ولا أكثر باقي؟
لا انا اروح يوم 12 بالليل، ارجع يوم 15.
اوكي اذا
يعني
تقريبا
12 الصبح المؤتمر 12 و13، بس مفيش طيران بعد.
Last are you coming?
والله ما حد مطيني خبر ليه هسه.
They usually very slow with the invitation.
يعني
I received the invitation
ضلنا
بس
قالت لي سكرتيرة هذا، وهي سكرتيرة الجمعية، قالت لي انت باعتبار اني امثل الجمعية في كردستان، يعني مو هسه من زمان يعني، بس هاي سنتين صارت هالمشاكل فشوية صار يعني ابتعدنا عن الوضع. فالاساس اول اجتماع اذا يتصلوا بي يعني اقدر الصبح اجي بالطيارة، هاي سهلة عليه يعني ساعة اوصل يعني ما عندي مشكلة.
اوكي
جمال انا جاي ان شاء الله.
ان شاء الله ان شاء الله ننبسط هناك ان شاء الله.
هذا انتظر اذا بنا قالت تعال
مايكل
راح اجي 100% راح اجي.
مايكل محمد قناوي ما بعتوش اللينك بتاع البانلست.
طب الميل بتاعه موجود يا دكتور جمال؟
دكتور
ابعتوا
ممكن تبعت
لي
لي
على الواتساب وانا ابعته له يا مايكل.
دكتور لا حضرتك ابعت لي اللينك وانا لازم ابعته له من الزوم اكونت نفسه علشان يبقى باناليست على طول. ايميل بتاع الدكتور بس.
الايميل بتاعه بس يا دكتور جمال.
طب ماشي، انا هقول له يبعت لي الميل بتاعه. ماشي.
I'll send it to you جمال. I'll send it to you جمال in a second.
اوكي.
انا will call him.
دكتور جمال.
ايوه.
انا دزيت لك الابديتنج الجديده. انا دا احاول هسه حاليا ما اعرفش ازاي حسوي الداونلودنج مع الابلكيشن، مش شيء دزيت لك اياه لك.
ده ما كانش هو وصلني، بعته للدكتور محمد لاشب. انا بعت لك البرزنتيشن بتاع الدكتور لاسي يا محمد.
اوكي
عشان لو في مشكله مايكل يعرضها، مفيش مشاكل.
اوكي
عشان انا دا احاول هسه حاليا ما اعرفش ما اقدرش اجيب البتاع ده على الشاشه.
هبعتها للدكتور مايكل على طول.
اوكي ممكن نبتدي بقى يا محمد. لا تقول.
هبعت بس البرزنتيشن يا دكتور جمال.
اوكي.
للدكتور مايكل والايميل بتاع الدكتور محمد قناوي.
انت عارف انا مسافر الامريكان اكاديمي بالليل، يعني كمان 3 4 ساعات كده.
سلامة.
بالسلامه ان شاء الله. تروح ترجع بالسلامه.
الله يخليك.
We can start.
احنا الجست نيشن بتاع الامريكان اكاديمي السنه دي، جمعيه جراحه العظام المصريه.
ممتاز. طب ازاي واحد يبقى عضو في الاي او اي؟
انت اصلا عضو.
تمام ممتاز.
عايزه كلام يا
تسلم حبيبي. انا عايز اجي لمصر واشترك في مؤتمرات مصر. يعني انا
طبعا
تمتعت كثيرا في مؤتمر 2021 حقيقة يعني.
انت تيجي تقعد معانا اصلا خلاص.
تسلم حبيبي. والله مصر حلوة يعني. حلوة قوي حقيقة يعني. ناس ثقافتها طبيعتها حلوة قوي جدا يعني. قد يرتاح هناك يعني تعامل.
دكتور جمال we are ready to start.
اوكي.
بسم الله الرحمن الرحيم. اولا كل عام وحضراتكم جميعا بالف خير بمناسبه شهر رمضان المبارك، أعاده الله علينا وعلى الأمة العربية والإسلامية جميعا بالخير والبركات.
آمين.
It's a great honor for me to announce for the beginning of this big scientific day, the Pediatric Speciality Day, which is a great collaboration between the Egyptian Orthopedic Association and the MIPOS, the Middle East Pediatric Orthopedic Society. First of all, I would like to thank my dear professor, Professor Gamal Hosni, the president of MIPOS, for his great effort for contributing to this collaboration and for making this mega event real. This mega event represents the continuation of 5 years of continuous medical education online, which we have started 5 years ago. My name is Muhammad Al-Ashhab. I'm a professor of orthopedic surgery and dean of Banha Faculty of Medicine and one of the members of the administrative board of the Egyptian Orthopedic Association. Also, I would like to thank all our dear speakers from all over the Arab world. Many thanks for sharing your experience with our young trainees. Thank you so much for being with us. Professor Gamal will start the announce for the start of this mega event, mega scientific event. Please, sir.
Thanks, Muhammad. السلام عليكم يا جماعة. مساء الخير.
Salud.
Dear friends, it's first of all, I would like to thank Professor Muhammad Al-Ashhab for his initiative. Professor Muhammad is the dean of Banha University, and we know him quite well. He's a great teacher, and he started this project a few years ago of online teaching. So I would like to thank him. I would like to thank my friends in the board of the Egyptian Orthopedic Association for their continuous support. I would like to thank also Sattar, my friend Sattar, for his initiative also to start this cooperation between the Middle East Pediatric Orthopedic Society and the Egyptian Orthopedic Association, and also my friends as the board of the Middle East Pediatric Orthopedic Society. We started this initiative because we have to tell the world that we should have our opinion, or the people has to listen to our opinion in pediatric orthopedics. We know that the world is 8 billion people. 90% are living in Asia, in Africa, and 10% in Europe and the States. And I always wonder why 10% of the population of the world wants to teach 90% of the world everything. In spite of most of the children population are lying in this 90% part of the world. And if I show you the map of the population of the world in the next 20 years, you will find that the pediatric population in this area of the world is booming, while in some countries in Europe, it's getting less and less, and even minus if you look to Germany. That's why I think in the last meeting in the American Academy, you have the delegate from the EPOS, the European Pediatric Orthopedic Society, and he was talking about giving lectures and teaching programs in Africa or something like this. And I told him, this is very funny. Your pediatric population is very small, and you want to teach the people how to treat children. This is very funny. So we have to do more. We have to teach more, and we have to cooperate between each other and to do research and educational activities and so on and so on. So again, I would like to thank Muhammad for this initiative, and I would like to listen to Sattar for a few days. Sattar.
Thank you very much. Thanks, Professor Jamal. Thanks, Professor Muhammad Al-Ashhab. I always say that you don't have to make the same mistakes. If you talk to your colleague, if you listen to your colleague, particularly the experienced one, you learn from their mistakes so that won't happen to you. And now technology have improved a lot. Really, we can, like we just have finished iftar, all of us, we had in the comfort of our home, we can sit and we can discuss these things. But it needs the rules and the vision. And I'm really, really proud that Jamal Hosni, as the president of the Middle East Pediatric Orthopedic Society, in collaboration with the other colleague from Egypt, set this program so that we'll share our experience and we learn from each other. Thank you very much for all. Thanks for the who's attending, and thanks for the panelists. That's me, Jamal.
Okay, thank you, Sattar. Muhammad, we can start now, just
Yes, please, sir.
Professor Osama.
Our first speaker will be Professor Osama Hijazi. Professor Osama is one of the pioneers of pediatric orthopedics in Egypt and the whole Arab world. Professor Osama will speak about clinical examination in pediatrics. Please, sir. Professor Osama. معانا يا فندم؟
معاك بعمل شير.
اتفضل يا فندم، اتفضل سعادتك.
الصورة وضحت كده يا دكتور محمد؟
بدأت يا فندم، هي لسه بتشير سعادتك.
اوكي.
لسه مش شير دي يا فندم. شيرت عند سعادتك يا دكتور أسامة بيه؟
شير ده هي بتحمل دلوقتي يا فندم.
بتحمل صح. تمام يا فندم، تمام سعادتك. اتفضل يا فندم سعادتك.
عامله سلايد شير ولا الصوره صغيره؟
لا كبيره، مظبوط.
لا كبيره يا فندم، سلايد شير.
اتفضل.
يس يا دكتور معاك.
اتفضل يا دكتور اسامه بيه.
مساء الخير، كل سنه وحضراتكم طيبين. I will give presentation about pediatric orthopedic clinical examination.
لا كده سلايد شير يا فندم، كده عايزين سلايد شير يا فندم، كده مش سلايد شير. ايوه تمام يا فندم، اتفضل يا فندم.
Orthopedic clinical examination of a pediatric patient, the examining surgeon has to be very observant in picking up details that could help in diagnosis. Physical examination in pediatric patient varies depending on age. There is 4 categories: the newly born, which ranged from birth up to 2 months, infants and toddler from 2 months up to 3 years, children from 3 years up to 10 years, pre-adolescents and adolescents from 10 years up to 18 years. A guide for assessment of pediatric patient based on following criteria. Start by age, evaluation of general features, especially height and weight, evaluation of gait if there is any gait abnormality, and look for upper and lower extremities and spine. Then finally do a regional examination. Regional examination examined for the deformity, swelling, wasting, and skin changes, range of movements, limb length discrepancy, and brief neurological examination. The regional examination of pediatric patient based on 5 criteria: deformity, swelling, wasting, and skin changes, range of movement, limb length discrepancy, and brief neurological examination. We start by examination of a newly born. Musculoskeletal assessment of newborn. We should look for abnormalities, asymmetry, limited movements, and motor weakness. The physical examination of a newborn start by examining the feet of the baby and check asymmetry and deformities. Then check the hands for deformities. Then check passive and active upper and lower limb movements. And then finally look for hip, thigh, and knee. Examine the feet for deformities. The most common deformities in feet are metatarsus adductus, talibus equinovarus, and finally calcaneus valgus. Foot deformities formed a very high number, nearly 43% of all deformities: talibus equinovarus, metatarsus adductus, and calcaneus valgus deformity. Check hands for deformities. Check for the common deformities in the hand: polydactyly, syndactyly, and radial club hand. Then check motor weakness. Common motor weakness in a newborn: upper limb weakness secondary to brachial plexus palsy, lower limb weakness secondary to meningomyelocele. Then check for hip dysplasia. Hip dysplasia in newborn could be assessed by looking for asymmetrical skin creases, Galeazzi sign, which is different lengths of the lower limb, and finally test for abduction deformity, limited abduction. Then come to clinical examination of infants and toddlers from 2 months up to 4 years. That age group, the common problems should look for temporary deformities, bow legs, genivalgum, and foot problems. Deformities in that age group may be temporary, may be physiological, and corrected by growing, by age. Then look for gait disorder in early walking, which is mainly in-toeing or out-toeing or tip-toe gait, and check for developmental and musculoskeletal disorders. Gait in early walking may be in-toe gait or out-toe gait or tip-toe gait. This is problem of many parents. Then, while the patient is walking, check the foot progression angle. The foot progression angle used for assessing the rotational profile of the lower limb. Its normal foot progression angle is from 10 to 15 degrees of external rotation. Negative foot progression angle indicates in-toeing. Positive foot progression angle indicates out-toeing. Then, Staheli profile to assess any rotational deformity of the lower limb. We start by examining hip internal rotation and hip external rotation. Hip internal rotation from 20 to 60 degrees, external rotation from 30 to 60 degrees. Then check for thigh foot angle to assess any rotational tibial torsion and check the foot velocity. So the Staheli rotational profile in components of the examination of hip rotation, hip internal rotation, and hip external rotation, thigh foot angle, and examining the foot. There is a case of external rotation is limited. A normal external rotation is from 30 to 60. Here is 20 degrees. Internal rotation is about 90 degrees. Indicates antiversion of the femoral antiversion. The femoral antiversion is graded by severity of internal rotation. Staheli profile. A mild inversion from 70 to 80 degrees, moderate from 80 to 90 degrees, severe greater than 90 degrees. Then you look for foot deformity in that age, bisplanus or planovalgus foot, and metatarsus adductus. This is how to measure, to assess the metatarsus adductus. Then we look for temporary deformities of the lower limb, bow legs, and genivalgum. We assess by measuring the intercondylar and intermalleolar distance and measuring the tibiofibular angle in each deformity. Then, if there is any deformities or asymmetry or limited movement in the upper limb, this may be in that age group from up to 2 years, may indicate obstetric brachial plexus palsy. The arm is held in adduction and in rotation. And then we assess shoulder, elbow, forearm, hand, and assess the motor weakness. It's a case of obstetric brachial plexus palsy. Children, clinical orthopedic assessment of children, clinical orthopedic examination of a child from 4 years up to 10 years. There's assess for deformities, range of movements, abnormal gait, and neuromuscular disorders. Deformities in the lower limb from 4 to 10 years may be bow legs, may be genivalgum, may be tibial torsion. Deformities also may be cubitus valgus, may be multiple joint deformities, may be cubitus varus. Deformity assessment based on measuring the degree of the deformity for the upper limb, we measure the carrying angle. For the lower limb, we measure the tibiofibular angle. Measuring the tibiofibular angle as the same, we measure the intermalleolar and intercondylar distance, and we measure the tibiofibular angles. Also, in that age, we make assessment for brachial plexus palsy, assess for deformity, and shoulder, elbow, forearm, and hand, and assess motor weakness. Clinical assessment of a joint in that age group, we could assess deformity, then assess swelling, range of movement, and limb range discrepancy. Clinical orthopedic examination of adolescent from 10 to 18 years of age. The common problems at that age are foot problems, the flat foot or discavus, hip problems, the slipped upper femoral epiphysis, spine problems, deformities and back pain, neuromuscular disorders. Assessment in that age group, we start by assessment of the flat foot. We assess the appearance of the foot, then assess the flexibility of the foot, then look for heel valgus and the midfoot valgus and the heel core tightness. For assessing a case of flat foot, we must consider all these factors. Assess the appearance of the foot, then assess flexibility by hyperextending the big toe or ask a patient to stand on tiptoes, then assess heel valgus from behind, and assess midfoot valgus and assess heel core tightness. This is a case of how to assess this flexibility. This condition is a rigid flat foot. Then a clinical assessment of this cavus. We assess the appearance, the cavus, arched foot, foot adduction, hind foot varus, or toe deformities. These are the components on assessing this cavus must consist of assessing the degree of cavus, the forefoot adduction, the hind foot varus, and toe deformities, and assess the flexibility. How to assess? This is forefoot adduction. This is hind foot varus. This is high arched foot with toe deformities. Then assess the flexibility by doing the Coleman block test. Coleman block test is useful to assess the flexibility of the hind foot deformity. We put a block placed under the lateral border of the foot and the heel, while the patient is medial side of the floor, lying on the floor. Observe the correction of the heel varus. If the heel varus is corrected by putting this block under the lateral border of the heel, this means this is a flexible deformity and it's have a role in decision making for management. That age group, if there is hip and thigh pain, which may be associated with limbic or inability to walk, limb is held in extended rotation, this denoting slipped capital femoral epiphysis in that age group. So the key points for clinical assessment of pediatric patients based on age, assessment of the deformity, then assessment of range of motion, then limbless discrepancy, and finally neuromuscular examination. And thank you.
Thank you so much, Professor Osama Hijazi, for this very interesting talk. If we have any questions to Professor Osama, we can allow 5 minutes for question. Okay, thank you, sir. Our next speaker, Professor Gamal, second speaker.
Yes.
Okay. Our next speaker will be our great professor, Professor Gamal Hosni. Professor Gamal will speak about congenital longitudinal lower limb deficiency. Please, sir.
Congenital longitudinal lower limb deficiency. We're going to speak about proximal femoral focal deficiency and the incidence between 1 per 50,000 population to 1 to 200,000. Fibular hemilia, 7 to 20% per million live birth. Tibial hemilia, 1 per million live birth. Remember, guys, these are the statistics coming from the Western world. I don't think this is true in our area. Why? Because the consanguineous marriage in Egypt is about 30% of marriages. In Saudi, it's 50%. And I think in the other Arabic countries, the percentage is very high. And there is no consanguineous marriage, in Europe or the States. So this percentage is not true. We have higher incidence than this. And this is an example of fibular hemimelia. You see absent lateral toes, and tibial hemimelia, and congenital short fibers. Amputation is not an acceptable way of treatment. Amputation is considered as a treatment in many areas in the world. but our patients, they refuse amputation. So this patient, you know, this with congenital short femur, you see this is 40 centimeters wooden block because they refused amputation, and this also, you see. The treatment of protocols. The problem with the treatment of protocols, they are always belonging to the Western part of the world. And as usual, they put many ideas and many decisions based on the hypothetical ideas. So if you look to at the English literature, you see that you find that if you have less than 3 raised foot, that means non-functional foot, and you have to do an amputation. So if you look to this patient with bilateral fibrohemilia, she has only 1, 2, and you know, severely deformed too. But look the way she walks at the age 20. She can walk. It's functional foot on both sides. So forget about hypothetical ideas. You see which type of shoes? Normal. She can even run. See. When they talk to you about the advances in limb reconstruction or congenital deformities, they talk about diamonds, brilliant, sparkling diamonds. When they talk about recent advances, they talk about Ferrari. So if you don't have diamonds or you don't have Ferrari, you don't have advances. You're old-fashioned. They always convince the people that way. But you can read my article. This is marketing. It is not science. They just changed the world of science into just marketing. You can read this, my paper, my letter to the editor in the Clinical Orthopedics and Related Research regarding that many ideas regarding the congenital deformities are just marketing. So you have to think about scientific updates and not branding. Brands often use exaggerated claims to make their products or services seem more impressive. So they always use the words the best, super, and most advanced. This is how brands use illusory superiority to sell the dream. They just sell you the dream. There is no super, no most advanced, just words. They repeat the words again and again and again. So they create false ideas. They create false beliefs. Our management protocol, based on new classification, based upon fair number of patients, long follow-up, late diagnosis, single-stage surgery, one-day hospitalization, and new methods of limb reconstruction to avoid amputation. For proximal femoral focal deficiency, we published just 2 months ago my classification based on 927 patients in the Journal of Pediatric Orthopedics, Part B, and this is the classification. 1, morphological abnormalities of the femur. 2, congenital absence. Total absence or partial absence of the proximal femur. 3rd type, abnormal proximal femur with apparent nexoarthrosis and coxa or coxa vara, and just short femur. It's normal femur, but short. You can read it in the Journal of Pediatric Orthopedics, Part B. And this is type 1. You know, the femur is all there, but it's abnormal. It looks like transverse femur. Total absence. In this picture, you see this is the tibia. The medial part of the head, the medial part of the plateau takes the shape of the proximal femur. And this is the beauty of neglected cases. They don't see the patients at the age 26 with no treatment or 34 with no treatment. And this is how we make the classification, by following the patients, not to just have an X-ray, one X-ray, and say this is type 1, type 2, or type 3. So with the long follow-up of the patients can give you a new classification. Partial, if you don't see the proximal femur. Third type, abnormal proximal femur, apparent neck pseudarthrosis. You don't see a link between the head and the proximal femur, but this is not pseudarthrosis. This is apparent pseudarthrosis. There is fibrocartilaginous tissue in between. Coxavara, it's the same with Coxavara. Type 4, the whole femur is there, but it's short. So we have 4 types. Also, the new classification is going to be published based on 566 patients on tibial hemimelia. Type 1, the whole tibia is there, but short. Type 2, the distal femur is absent. Type 2, the distal femur, tibia is absent. Type 3, only we have the proximal tibia. Type 4, diastasis. Type 5, tibia and femur, tibia and fibula. There's diastasis between them with a small tibia. Type 6, more than 50% of the cases you have complete absence of the tibia. Our philosophy is 3-on-1. That means one stage of procedure. So if we look to the tibial hemimelia type 6, which is complete absence, we do gradual centralization, and correction of the deformities at the same stage. And this is an example with the complete absence, one stage. Three-in-one operation. In the ankle, we do just tenotomy, no fibula shortening at all. We keep the fibula. And at the same time, we do centralization, but no trials to correct the deformity with the centralization. And we put all-wire frame without image intensifier. And with this wire frame, after we do the centralization, we put K-wire in position for 6 weeks. And we don't do correction of the knee deformity. And we do tenotomy and the gradual correction of the foot and the ankle deformities. Immediate postoperative X-ray. And we see wires keeping the head of the fibula in position. And this gradual correction of the foot, after 6 weeks, we remove the wires of transfixion, and we start the correction of the knee deformity. So gradual correction till we get full correction of the knee and foot deformities. And we keep the centralization, the centralized head in position. And you have any displacement, you can correct it. And this is the end picture in the frame with overcorrection of the knee and foot. And then we remove the frame under anesthesia. And of course, you have knee instability. Medial lateral instability. And the ankle have medial instability. It's correctable, but unstable. Usually we do some sort of derotation at the same time. And we put wires, transfixing wires in the knee and retrograde wires in the ankle to keep them in position. Then we put cast. And this is the picture afterwards. Limb length. We don't remove any part of the fibula. It's a precious, because it's very difficult to lengthen the fibula afterwards because of the instability. And this is after 3 months. And you see with the follow-up. For type 2, we do the reversed ankle technique. What's reversed ankle technique? You see? with the reversed ankle technique, this is the fibula and this is the tibia. We'll get the tibia lower down 11 millimeters below the fibula because we have medial instability. So we do a reversed ankle to keep it in position like this one. It's a stable ankle. We call this reversed ankle technique in type 2. For neglected deformities, the conventional treatment again is amputation. We don't think so. They don't see patients with fibular hemilia at age 20 like this patient. You see, we did lengthening. And they always claim that you are going to have a stiff knee afterwards because this is not normal knee. This is immediately after removal. كمان على الآخر. افرد. اتنين. ارجع. So our management approach includes new classifications, again, based on follow-up and late diagnosis, single-stage surgery, one-day hospitalization, new methods of limb reconstruction to avoid amputation. Some people think that, is it a necessity? That means necessity is the mother of invention. This is not true. It's rather strategic planning. This is our strategic planning. We don't need fancy nails or something like this, or super operations. I think we have to revalidate the conclusions derived from the English literature, with the majority of papers reporting a relatively small number of patients operated on by many surgeons over a long period. We need a paradigm shift. Thank you.
Thank you so much, Professor Gamal Hosni, for this interesting talk. My dear professors, I have the schedule done by Professor Gamal. This day constitutes 3 sessions. The first session, 4 lectures. The first speaker was Professor Osama Ghazi, and the second was Professor Gamal Hosni. The third will be Professor Les Hawizi, and the fourth will be Professor Muhammad Hosni, and the moderator of this session will be Professor Osama Ghazi. The second session, the moderator will be Professor Sattar and Professor Hassan al-Barbari. First speaker will be Professor Sattar. Second speaker will be Professor Iftikhar. Third speaker will be Professor Kenawi. Fourth speaker will be Professor Hassan al-Barbari. And fifth speaker will be Professor Mahmoud Mahran. The third session will be moderated by Professor Saleh al-Saifi and Professor Mustafa Shirbini. First speaker will be Professor Saleh. Second speaker will be Professor Abdullah, and third speaker will be Professor Mustafa Shirbini. Professor Osama, you are the moderator of this session, and please, sir.
The next speaker will be Professor Las Hawizi from Kurdistan. He will give a talk about early diagnosis of DDH.
Please, can you share the presentation, doctor, if you don't mind?
Dr. Gamal, the presentation with us is in the form of PDF, not PowerPoint.
I sent you another one.
Please send me another one.
I did.
You did it? Just one moment, sir. Dr. Michael, I sent to you the presentation.
Okay,
Dr.
Dr.
Michael?
Okay, I will download it now.
Okay. Sorry, the presentation was in the former presentation, the previous presentation was in the
Yes,
form
because
of
the last version you sent, Dr. Las, was PDF, not PowerPoint.
No PowerPoint, was PDF.
The last one
was PDF, not PowerPoint. So we uploaded the early one.
Okay, no problem.
No problem.
Just 1 minute, sir.
I'm sorry, I'm trying to.
No.
Okay.
No.
Yes, this is now. Okay.
Okay.
Slideshow, Dr. Mike.
Please ask me to just say next, and I will scroll the slides.
Thank you very much. So thank you very good evening. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Professor Las Havezi. I'm working in DDH for more than 30 years. And now this lecture, we have early detection and management of
Hello.
DDH.
Alaikum
Hello.
salam. How are you doing? Fine.
Do you hear me?
One like
Do you hear me?
Yes.
Yes, sir.
Yes.
Yes. Please, can we start the next slide, if you don't mind? Next slide, please. Okay. This is just a refreshment. I think we don't need that, but developmental dysplasia of the hip is a condition where the hip joint doesn't form properly, leading to instability and potential long-term consequences. Early detection and treatment are crucial for optimal outcomes. Next, please. Okay, this is, this was very nice word by Professor Jamal Husni. He said, now, all this formation we are getting from the books, which are from Western countries. This is the point.
Yeah.
So, DDH affect plus 1 to 3% of newborn worldwide. Risk factors, we have family history, breech presentation, although new research suggests that this is less significant than previously thought.
On Zoom.
Patients, oligohydramnias, cradles, and swaddling. Next slide, please. Now, if you look at these two things, which is very popular in the Middle East, in Iraq, in Kurdistan, Afghanistan, Iran, Pakistan, and so on. Now, if you look to the right side, is the swaddling, and to the left side is the traditional landing, especially Kurdish people and Iranian people, Afghanistan, even Pakistan, they use it. These are very, very dangerous when they use in the early life, and this will increase the rate of DDH in children. This is really a big problem. Professor Clark, we had in 2018 in Dubai. He said that he went to Japan in 1966 and advised the people there to stop this type of swaddling and tightening the legs. After 10 years, he returned back to Japan. He found that 50% of DDH cases decreased in Japan because they didn't use the swaddling and didn't do tightening of the legs. Next slide, please. Now, we had the researchers here in Kurdistan. This is just confirmation of Professor Jamal's speech. Now, British presentation, in all the books, they say it's a very major reason for DDH. Now, in our researches, where with two obstetricians for 5 years, we found that only 6.5% of cases of breech presentation develop DDH. The one which is dangerous of presentation of breech when the foot, the leg, the pelvis will be in full flexion and extension of the knees. These are really big problems. So not all the things which is written in the books is it's the same thing in our country in the Middle East. Next, please. Now, diagnosis. Always in the past, when we spoke about DDH, they spoke about two historic clinical examinations with Ortolani and Barlow test. Nowadays, in all the texts, now in the practice, everything now, we prove that negative Ortolani and negative Barlow test does not mean there is no DDH. This is the point. So, although all you know, the clinical examination and Barlow test for diagnosis prove that the time that negative Ortolani and Barlow test will not exclude DDH. So now the most reliable test to give the diagnosis 100% is ultrasound tip using graph method and the static ultrasound examination. And if you look this is the classical way where the probe of the ultrasound should put in this device so that you will get exactly controlling the position of the probe, because any deviation right to left or angle of deviation, it may give a false result. Next, please. Okay, this is the graph scale system. You'll see we have all the types, type 1, type 2A plus, type 2A negative, type 2B, type 2C, type D. Type D, type 3, type 4, these are the centric type, dislocated, and other types are, we can consider dysplasia. This graph scale system is not only, it will give you the type of the diagnosis, it also give you the way of treatment. Because, for example, when you have a dislocated hip, the classical way that all infants should be put in a splint from age 1 day to 6 months. It's no more used now. When you have grade 4 or grade 3 or grade type 2D dislocated, they should be treated after supervised physiotherapy to put in POP, even if the infant is 3 days old. This is the point. Thank you. Next slide, please. Now, this is, you see very clear. I'm sure all of you know that. This is the ultrasound of the hip, which is non-invasive, easy. Although Professor Graf, I worked with Professor Graf in 2004 in Stoß Alpa in Austria. I stayed with it for about 2 months. And there in Austria, they are using ultrasound from 1993 as a routine daily for all infants. Please, next. Yes, these are the types because this is very clear now. When you see the ultrasound, you see every part of the joint, the head, the os ilium, the labrum, everything here. So you will give a panoramic view. It's not like an X-ray, which you cannot see the head because most of the head and the sternum are cartilaginous. Next, please. These are, you can see graph classification of the blood vessels of the hip. You can see we have type 1, type 2A, type 2B, type 2C, type 3, and type 2D, and we have the type 4. You can see here it's very clear. It gives you a panoramic view, so it gives you 100% diagnosis for the DDH. Next, please. Now, in treatment, this is, I say we believe that graph scale system is not only for classification, but also to give us the treatment strategy. The whole theory that all infants with DDH under 6 months must be put in public harness or separate is outdated. The treatment principle, according to graph, is dislocated hip should be put in spica cast even the first few days of life. We mean type 2D, type 3, type 4. Of course, it should be preceded by supervised physiotherapy to make the joint loose, and reduction must be smooth, i.e. without tension when reduced in the sternum. This process sometimes may need percutaneous tenotomy. In cases of physiological immaturity, in type 2A, less than 3 months of age, there is no need for treatment, but preferably avoid swaddling and cradles. Type 2A negative, public harness is a good choice. Type 2B also captured by public harness because these cases are not dislocated. It is only a stabilized dysplasia. All above infants must be subjected to supervised physiotherapy prior to the split, as tight adductors or contracted joint, if put in spleen without preparation, it may increase the rate of avascular necrosis of the head of the femur. Next, please. Now, before that, there's one slide missing here that the best way to control DDH in any society is universal screening of all infants. We have 2 types of screening. We have selective and we have universal. Selective in countries when they have not enough personnel for doing this, that you are choosing the patient with family history, female, any breast presentation, okay, any ortolani or Barlow positive, for example. So the best way to control DDH in any society is to do universal screening for all infants. According to graph, all infants in the first 6 weeks of life, they have a very rapid growth of the hip joint, which is already immature in all infants. So first 6 weeks of life is the golden time for diagnosis and treatment. So please, the first week, try to do ultrasound for infants so that we can treat them perfectly, because there is very rapid growth in the first 6 weeks of life, of course, if the head is lying in the sternum. And thank you.
Thank you, Professor Jihad Hawadi. Now, next speaker will be Professor Muhammad Hosni, who will present a talk about neglected TDH.
My dear Professor Osama, we can allow 10 minutes at the end of each session
Yes, okay.
for discussion and taking questions according to the schedule. Thank you so much, sir.
Thank you.
You see the presentations already?
Yes, sir.
Yes,
Slideshow.
Slideshow. Okay. Just a minute. دكتور محمد معلش انا يعني ظهرت المحاضرة اصلا؟
ظهر
طيب
لا بس عايز سلايد شو يكتب.
سلايد شو يا دكتور محمد بيه؟
هي بس مش ظاهرة عندي اصلا.
لا هي ظاهرة عندنا يا فندم.
المشكلة ان السكرين نفسها مش ظاهرة عندي.
حضرتك ممكن تقفلها وتفتحها تاني يا دكتور محمد بيه.
واحدة ماشي. شير اوبشنز.
ستوب شيرنج واعمل ري شير تاني يا فندم.
معلش. مش مدياني الاوبشن بتاع الستوب شيرنج، حتى هو الشيرنج عندي بتفتح one participant can always share at a time, multiple participants share simultaneously, advanced sharing options.
وحرك السهم كده يا دكتور محمد على الشمال خالص هتلاقي فيه.
اعمل كده والله. الفيو مديني سبيكرز والجاليري بس مش مديني
السهم عايز
مايكل
يتحرك.
اعمل ستوب شير يا مايكل انت.
اها.
هو لازم الدكتور اللي يعمل ستوب
لازم
شير.
الدكتور
انا I will
محمد اللي
try.
يعمل ستوب شير يا فندم.
المفروض من عندي صحيح، بس هي مش عارف مش ظاهرة مش عندي.
Okay, I will try to share another presentation. Maybe it will stop Dr. Muhammad
تمام
presentation.
تمام. الاوبشن الوحيد اللي مديهوني الليف.
Okay.
اوكي ري شير تاني بقى يا دكتور محمد بيه. كده وقفت.
طب هو المشكله انه بيعمل شير من باوربوينت، مش بيعمل شير من من الديسكتوب.
ممكن تبعتها لنا يا دكتور محمد؟
ثانيه واحده.
ابعتها لي وانا هبعتها للدكتور مايكل.
نبتدي المحاضرة الثانية وعلى ما تحل المشكلة يا محمد.
تمام.
بس هي في another session يا دكتور جمال بيه. المحاضرة
دي
اللي بعدها.
المشكلة عشان الوقت.
هبعتها
طيب،
للدكتور الاشبي اوريدي، بعتها لك يا فندم.
بعتها لي. طيب just 1 minute يا فندم.
بالظبط كده.
بعتها يا فندم.
اوكي دكتور مايكل هبعتها لحضرتك. شير ات.
Okay, prof.
شير ات دكتور مايكل. اتبعتت لك.
Okay. Just seconds. Okay, great. Professor Muhammad, you can tell me next.
تمام. شكرا.
Slide show please. Yes. Please sir.
السلام عليكم جميعا. Sorry for the inconvenience and يعني problems, technical problems. First of all, I would like to thank طبعا دكتور محمد الأشهب, my dear friend and Dean of Faculty of Medicine, Banha University. Great thanks طبعا to دكتور حسني, دكتور جمال حسني, our mentor في ال Pediatric Orthopedics في مصر, wal head of the MIPOS, Middle East Pediatric Orthopedics Society. I would also يعني الحقيقة like to thank Dr. Lass for his يعني impressive presentation. He made my يعني presentation much easier because he presented almost everything about the diagnosis in DDH. I can't agree more than prevention is better than cure in management of DDH, and that early diagnosis is the best thing to treat such difficult cases because of the wide spectrum of anomalies that we face in pediatric populations in our community and worldwide. This is a presentation about late presenting DDH cases or late DDH management. Next, please. What represents late DDH? In fact, I used to work in Germany for 5 years as a pediatric orthopedic surgeon. And in Germany, for instance, they consider late DDH if the case is diagnosed after 6 months. And if this happens, you have medico-legal actually problems. And if any missed cases are presented after 6 months, they have medico-legal problems and they have to, ask the surgeon or the pediatrician or even the pediatric orthopedic consultant who actually examined the case during infancy or during the first few weeks of life. Why is this case missed? So we used to learn all about graph classification. We used to take courses by Professor Graf himself, and we used to do ultrasonography by ourselves. It's done actually by a pediatric orthopedic surgeon, not by a radiologist, which is actually very convincing and meaningful. So diagnosis is better than cure. I think DDH should be examined. All the cases should have universal screening when you have the chance and when you have the fund for this. The best time for screening and the best time for ultrasonographic examination is after 2 weeks. We have to remind you with this. I know that you are quite well acquainted with this information, but just a reminder that ultrasonography is actually very crucial and very important for the diagnosis of all cases of DDH. In literature, late diagnosis is considered in most of the literature as diagnosis after 24 months. It means after 2 months. And in other words, in other countries, they consider walking children after the walking age as late presented or late DDH. So according to the socioeconomic status, according to the conditions of the country, do you have universal screening, selective screening, or you don't have screening at all? So late presented DDH can actually, the term itself can be confusing for some doctors. Next, please. DDH, as we all know, DDH is a spectrum. DDH is actually not a dislocated hip, not a subluxated hip. It's also a spectrum. And what we are confronted with in most of the cases, especially after walking age and late presented cases, are the dislocated hips. But after maybe 25 years of experience in DDH, I started doing this in 2000, year 2000. So actually more than 24 years now. The most difficult cases to treat are the cases with dysplasia and not the cases of dislocation. So what we are confronted with, the most cases that we see are actually presenting only the top of the pyramid and not only the whole pyramid. Most of the subluxated cases, most of these dysplastic cases are missed, and that's why they are presented at late age, and that's why we have serious problems facing these cases, because they actually started to walk, as Dr. Lass actually illustrated in his significant lecture. Thank you so much. Next. What happens when we wait? Actually, when we wait, the magnitude of the problems becomes more and more and more each and every day. So the limbus starts to change, labral changes, ligamentum teres starts to have significant changes, hypertrophy. The capsule starts to have this hourglass constriction. Iliopsoas becomes more short. We have more pulvinar tissue at the acetabulum. The adductor longus and the adductors start to be a little bit more tight, and you have to release them actually during your surgery or during your protocol of management. Transverse acetabular ligament, it also hinders the reduction. So the more you wait, the more difficult that you have to face, and the more solutions that you actually have to do to reduce the hip. And what we are aiming for is a stable concentric reduction. Next, please. Of course, as Dr. Lass also said, clinical examination. Now we are talking about clinical examination in walking children. In walking children, the most diagnostic would be limited abduction, less than 60 degrees. This is one of the most significant and most diagnostic tests for walking children to diagnose dislocated, of course, in unilateral cases. What if you have bilateral cases? You have the telescoping sign, you have the shortening, you have the gait anomalies that you actually diagnose while the child starts to walk, because he's coming to your clinic walking. So you have multiple tools to diagnose the DDH cases in clinical examination, and of course, a plain X-ray would be sufficient to heal, of course, to diagnose the problem. Next, please. As the child again begins to walk, the clinical finds becomes more significant. Exaggerated lumbar lordosis, Trendelenburg gait, waddling gait, limb length discrepancies in unilateral cases. This is what you are confronted with. This is what we see in our clinics in unilateral or bilateral neglected or late DDH cases. Next. Of course, we are all familiar with the Tonnes classification, and we are all familiar with the Hilling-Liner test, Hilling-Liner line, and the lateral Perkins lines, and the 4 quadrants, stages or grades 1, 2, 3, and 4, with the grade 4 being the significant or dislocated or high riding dislocations, which is the most significant. This is what actually we see grade 3 and 4 in most of the cases after walking age. And you have to be familiar with the acetabular index, the Remier's migration index. Of course, these are radiological findings. And if the index of the acetabular index increases more than 30 degrees, and this is suggestive of dysplasia, even if the hip is not yet dislocated. Next. This is a very important slide. Actually, nearing adulthood, we have other classifications, we have other forms of dislocation. As the head starts to go out after walking, it starts to accommodate. This is what we call remodeling. And this is also what we call accommodation. This is the child is walking and he's not walking with a normal hip. The growth of the hip, both sides, acetabulum and the femoral head are not well formed. They are not coapted. They are not growing in normal shape. So actually the angles would be altered. All the angles will be changed. And in these cases, in near adulthood, we have dysplasia, low dislocations, and high dislocations. Again, in high dislocations, you have to face one of two problems. The first would be if you have a false acetabulum. These actually patients walk with a false acetabulum with the head articulating with the lateral part of the ilium. This might be continuous with the true acetabulum, so you have to configuring two lines attached, the true and the false attached, or they are separated, or you don't find a false acetabulum with the head most deformed, and this is the type where you face the most difficult head femur deformities, or the most difficult proximal femoral head deformities. And the shape and the angles, everything would be changed at this type B with dislocated heads, high riding dislocations near adulthood or in adolescence. Next. Next, please. So what to do if we have to treat such a difficult case or a late presented case? What to do? First, you have to analyze the problem. You have to do you have to know what you are facing. Use all the modalities available. So you have to do an MRI if you'd like. This is important. Yes, it's crucial. Why? Because an MRI would show an AVN if there is an AVN in the head. It will show you about the labrum. It will give you an idea about the soft tissues, how the pulvinar is, the ligamentum, if there is any. And you have to see the capsule, if you have to see if the labrum is inverted, if you even have what type of cartilage do you have? Do you have even congruent head or not yet? Is it the head deformed? Is the head reducible? Will the head shape fit within the abnormal acetabulum and the development? So actually an MRI is useful, yes, in most of the cases. Again, CT scans and 3D CTs are very, very informative. They would tell you about your bony cuts, your procedures, your pelvic osteotomies. It would give you an idea about the best solution for each best cases. So you have to a la carte, and this is the best sentence I always use with my students, with my colleagues, that a la carte treatment is the best treatment in neglected or late DDS cases. Not all the cases has to be treated with San Diego. Not all the cases you have to perform derotation. Not all the cases you have to perform the triple attack, as we call it. No, you have to address the deformity as the one each and every side. Sometimes in bilateral cases, we do different pelvic osteotomies in different types. And different, the right side, you use a San Diego, in the left side, you might use whatever other Salter osteotomy or what other types of osteotomies you'd like. So basically, CT and MRI are a must in such cases. Thank you. Next. In late presented, that means up more than 2 years now, we have diminished acetabular capacity. What this means is what you end at the end of the surgery is what the patient gets for the rest of his life. So in younger patients, less than 2 years of age, if you reduce the hip concentrically, you would leave reminder that the remodeling potential of this patient is actually very high. So just reduction of the head below 2 years would leave the acetabulum ability to correct and to grasp the head in its new fixed, normal, concentric, reduced position. This is something that you don't have after 2 years. So if you end after 2 years with an imperfect reduction, a medial gap, or some sort of subluxation, the capsulorrhaphy is not tight enough. If you have any even trivial problem at the end of the surgery after walking age, this will persist and this will get worse. So you take very, very good precaution and caution at this stage, because at the end of these surgeries, you don't have acetabular remodeling potential at walking age. So this is very important stuff, and this has to be put in mind. Next, please. So what about treatment? You have done all the x-rays, you have done all the CTs and MRIs, you have now an idea about what you are performing, femoral shortening, derotations, antiversions, femoral head, femoral neck, what you are going to do, derotation or not, how much shortening are you going to need, what type of osteotomy are you going to do, what type of, this is also a surgical, of course, preference. So some would like to do San Diego for most of the cases, some would like to do Salters for most of the cases. I actually converted from Salter to San Diego a long time ago, and I have done this more than 20 years now. We're using San Diego and Dega osteotomies, of course, for most of our patients now, and the same is done at my unit with hip preservation team. So now we say that non-surgical treatment actually has no role in this part or for these patients, because we still hear some of our colleagues say, okay, if you diagnose the patient after 2 years, now you can leave him and he would walk, especially in bilateral cases, just leave him and he would walk with a waddling gait. And this is accepted. Actually, no, this is not accepted, not in the literature, not in evidence base. You have to reduce the hip. If you cannot, just refer the patient to a specific center who can actually would do this for you. So non-surgical treatment, conservative treatment has no role in treatment of DDH walking patients. Now, if we come to the open reduction, of course, open reduction, you have to address all the problems that we have talked about before. So you have to reduce the hip, you have to remove the pulvinar tissue, you have to release the transverse acetabular ligament, you have to tighten the capsule, you have to put the hip in a concentric position. You don't have to leave the gap between the head and the acetabulum, the floor of the acetabulum, clear it very well, reduce it very well, reduce the head of the femur in up to normal anteversion angle. Because in most of these cases, we have excessive anteversion. So you actually have to, in some cases, you have to derotate the femur plus shortening, of course. You have to reduce it. You have to do telescoping in its reduced position. It's not under tension. Avoid AVN. Do your best to provide the best surgery for your patients. And it's done as a la carte, as we mentioned before. So pelvic osteotomy, open reduction, femoral osteotomy, with or without derotation, is mandatory for most of these walking children. Thank you. Next. The last thing would be the position of the cast in these children. Actually, we do abduction 40 to 60 degrees in abduction hip spica, 1.5 cast, and we do no rotations. It's zero internal rotations. In the past, we have done slightly internal rotated position. Actually, this is not what we do nowadays. We have performed a new capsulorrhaphy technique that we use, that have been using for a long time, and this is published in JPO British. I'll provide it for our colleagues who anyone would like to see it. It's a new. It depends mainly as an anchoring. We do like an anchor effect. We take non-absorbable sutures at the pubic ramus, and it's very, very, very stable. We suture it laterally. We don't do a T or an L-shaped. We don't excise anything from the capsule, and it has provided us with a very good stable concentric reduction for most of the patients. Now we have patients 20 years or 25 years after surgery, and most of them are, alhamdulillah, are working well. We didn't need any total hip replacements in any of our patients till now. Of course, not all of them are skeletally mature, but none of them has performed THA till now. This is a very important slide. It actually compares the outcomes and complications if you find a patient, or if you treat a patient below 2 years or after 2 years. This is very, very important, and this is the aim of this presentation. You have AVN, very low incidence, up to 4 maybe to 7% if you treat these patients, good treatment in good hands. 4 to 7 or maybe 5 to 7% of the cases would have AVN. If you find the same patients within the same surgeons, the same hands, you have AVN in ratios up to 14%. This is double the AVN incidence. This is double the AVN risk in such as walking patients. Total hip replacement or conversion. This is also very crucial. Of course, you have to wait, and that's why we have to say that DDH follow-up for our treatment, you have to wait till skeletal maturity, and you have to follow them into adulthood to know if they have replaced the hip or no. So, and if early diagnosed, if they have treated with public harness, these are the best results, these are the best hands and the best centers, and that you have up to 0% if it's treated. You don't have to convert into total hip. Once you get a totally hip reduced concentrically and it's a normal position, you would never end by total hip replacement. This risk increases to up to 27% in open reductions and 57% in combined osteotomies, femoral and pelvic osteotomies. This has raised from 0 to more than 50% of cases might need total hip replacement in adulthood. So this is the mean of this. The earlier you treat these cases, the best you do them. The first surgery, you have to know this first surgery is the best and the golden surgery, as we call it. We have a la carte treatment for our patients. Not all surgeries are done for, not all steps has to be done for all the patients. Some of them have generalized laxity. Some of them you don't have to do shortening. Some of them needs femoral derotation. Some of them don't. We don't actually do VARS for most of our cases. We didn't actually need VARS of the proximal femur for most of our patients. This is just to show you that the risk increases and the complication rates actually raises very, very high if you do treat patients after walking age. Of course, Harris hip scores, the range and the functionality of the hip, the longevity of the after reduction, the need for another surgery, dislocations, all these hazards, all these complications raise if you treat patients even in specialized centers after the walking age. The quality of the score, the higher Oxford score, and everything changes after 2 years. So the best, it has to be done by a professional team, someone who actually done this for years, and someone who actually provide the best service for the patient to get the best result. So osteoarthritis risk as well. So actually these are some of the risks that we are confronted with in patients treated after 2 years. So the best thing would be early diagnosis and early treatment for all our children to provide the best life and the best quality of life in their lives. Thank you. Next slide. So take-home messages, I would say diagnosis is better than treatment. Diagnosis by ultrasonography in the first few weeks. The best time would be the second week. You have to perform ultrasonography. You have to know the differences between static and dynamic ultrasonography. You have to examine don't even rely on the reports sent to you by radiologists. You have to read the sonography. You have to know the position of the head. You have to know the alpha and beta angles. You have to read them and you have to do them if you'd like. And actually we are teaching them and to our students and to our medical orthopedic colleagues. They are doing it themselves in their clinics. So actually we do this in the neonates. We do this in the incubators. We go to the neonatal departments and we do this in the ICUs for our patients now at Tanta University. Of course, late presented is totally different for management than early presented cases. Actually, if you use it and your public has worked, that means that you have provided the best treatment for your patients and you have avoided major surgeries and provided the patients with up to normal life. Follow-up has to be done till skeletal maturity to know that success of it's not an X-ray. It's not just an X-ray image that it's reduced, everything is okay. No, actually, no. You have to wait till skeletal maturity to know that you have provided the best service for your patients. Walking age is you have to address all the problems. The best surgery is the first surgery, and all the problems has to be solved during this surgery. Avoid any inadequate treatment for such patients because this is going to get worse in the future. Thank you so much, Dr. Mohammed Hosni.
Thank you, Professor Mohammed Hosni. Now there is a question for.
I have a question.
ممكن أسأل دكتور أسامة بعد إذنك؟
اتفضل.
دكتور محمد حسني, whatever we do, we still receive neglected cases, even after 24 months of age. I have two questions for you. What is the maximum age that for unilateral dislocation that you would go on and do an open reduction? This is number one. And what happens if you get a 12 or 13 years old girl who is a professional athlete, squash player, that come for a sprained ankle and you do an X-ray and you find hip subluxation with increased central edge ankle? It was asymptomatic. So would you treat a radiologically abnormal hip that is not yet symptomatic? This is the second question, and repeating the first question, what is the maximum age where you attempt an open reduction?
Okay, thank you so much. Actually, this is a very interesting question, Dr. Mahran. It is also debatable in the literature. In my hands, I have reduced personally children with unilateral dislocations with 19 years of age. In unilateral dislocations, I would go for reduction till even 19 or 20 years of age. And I have done it, and I have 2 cases, and I have actually 10 cases more than 10 years, 5 of them are more than 15 years. So actually they are doing well, and they were females, they were getting married, and they couldn't do abduction. That's why they tried to solve the problem, and they are doing well, and none of them needed THR, total hip replacement till now. So the upper limit for unilateral cases, I would go for 19. I don't have an upper limit for unilateral dislocations. In bilateral dislocations, non-symptomatic, I would wait till pain starts, because sooner or later she will suffer from hip pain or a knee pain. In that case, this is justifiable to go and do a surgery because it's not going to be a slight surgery or a minor surgery. It's going to be a major surgery. With cerebral innominate osteotomy or redirectional osteotomy whatsoever, you have to address your deformity. I would wait for the signs and symptoms to appear, for the parents to understand the magnitude of the problem, and even to explain, because at the end, if you end by just slight pain or discomfort, or maybe a bit less range in an athlete, you would have a problem. So I would wait for the hip to pain. I would follow the patients closely, monitored for 6 weeks, every 6 months, and examination, clinical and radiological, each and every 6 months, and wait for the symptoms to appear, and then I would go for treatment. I would never start with an asymptomatic patients. In bilateral cases, of course. I hope I answered your question.
I have a question.
Of course.
Please, sir.
If you, Dr. Professor Mohammed Hasni, I have one question. This timetable, which is say 24 months, we have many cases, he's 1 year and a half, had been treated with public harness and failed. So, failed conservative treatment, you can do even upper reduction and salto rosetta or derotation at age of 1 year and a half. There are many textbooks, they have an age limit, they consider 18 months is maximum age of conservative treatment, as the stabilum will lose the power of growth after that. This is really what I mean, that not all the cases will depend on this timetable you put it in. So each case should be considered differently from the other cases. The other point you spoke that ultrasound should be done by only orthopedic surgeon. This is Professor Grass' principle, because the radiologist looks at the image only, while the orthopedic surgeon has a panoramic view of the hip, of the muscles, of everything. And thank you.
Of course. First of all, thank you, Dr. Lass. Actually, this is not, I actually was asked to talk about late presented cases. This is not the protocol of treatment. This is not the protocol of management in DDH in our institute. We start management by public harness for the first 6 weeks. If it's not reducible, if it's not achievable, you do a closed reduction with an adductor tenotomy, medial approach, Ludlow or whatsoever. You start doing surgeries even at the age of 6 months. So basically, I was asked to talk about 2 years. But in Germany, they would consider late DDH or neglected DDH after 6 months. But I started at the literature.
Exactly.
And I have met Professor Graf, and I have met, in Germany, I've worked for 5 years, and I said, in each year, you have to do ultrasonography for a whole month to be a pediatric orthopedic consultant. So basically, 1 month doing only ultrasonography day and night for all the newborn children. So basically, yes, it has to be done by a pediatric orthopedic surgeon, and that's why they have the universal screening. That's why it's working. That's why they never see late presented unless the case is coming from abroad in Germany.
Exactly.
My dear professors, we have to shift to the next session to stick to time. May I ask our dear professors, our dear speakers in the first session to answer the questions in the question and answer box or in the chat box by writing, please, because we have to stick to the time. At the end of the first session, I would like to thank Professor Osama Ghazi, Professor Gamal Hosni, Professor Las Hawizi, and Professor Mohammed Hosni for their very interesting presentations. Now we will shift to the second session. The moderator of the second session will be Professor Sattar El-Shiridia and Professor Hassan El-Barbari. And this session contains 5 presentations, each one 10 to 15 minutes. Professor Hassan and Professor Sattar, please, sir.
Hey, thank you very much. Thanks, guys. I'm Sattar El-Shiridia. I'm a pediatric orthopedic surgeon in Dubai at Jalila Children's Hospital. And Hassan?
Yeah, I'm Dr. Hassan Barbari. I'm a professor of pediatric orthopedics, Cairo University. It's nice meeting you in Ramadan. Kul sana wa tayyibin. We can start the session with Professor Sattar talking about Perthes disease.
Thank you very much, Dr. Hassan. Let me share my screen. You see my screen?
Yes.
Yes, sir.
Okay, guys. Thank you very much, Professor Hassan. Thanks for the lovely first session. Really, it was enjoyable and it was very informative. I hope we raise our bar to the same level. So, Perthes disease, it is 1 in 10,000, so it is rare. We don't know the etiology, although we know what happens after. We know the blood is stopped to the head, but we don't know why this happens. We really don't know the natural history. We think we know, but we don't. And there's no good outcome to measure. So everything I say in this lecture, take it with a pinch of salt, because the evidence behind it is not strong. So, but we know that in Perthes disease, after the insult happened to the femoral head, they pass into 4 stages: sclerosis, fragmentation, reossification, and healing. There may be different names for these stages by different classification. Okay, each one of these stages take between 3 months to 18 months. So the 3 months to 1 year. So the whole process can be as early as 1 year up to 6 years. In the first stage, which is the sclerotic, can be further classified into A and B, depending whether the height of the femoral head lost or not. In the second stage, which is the fragmentation stage, it can be further divided into A and B. A when there's only 2 fragments, while B when there are multiple fragments. In the third stage, which is the healing stage or the reossification stage, A, it is when the lateral border just start ossifying, but the quality and the height of it is not normal. And type B, where the ossification quality and the height is more than a third of the femoral height. And the final stage is the healing stage. There are different classification has been proposed. The very first is Cattrall classification, then Salter classification, then Herring classification, and the modified Elizabeth Downer classification. With Cattrall classification, he divided the Perthes disease into 4 grades, depending on how much of the femoral head has been fragmented or has been involved. With Salter and Thompson classification, which come after Cattrall classification, he simply gummed Cattrall type 1 and 2 in 1, and type 3 and 4 in 1. And he called the first is type A, when the less than the 50% of the femoral head involved, and type B, when more than half of the femoral head is involved. Cattrall proposed what he called the poor prognostic sign. There are some clinical poor prognostic sign, and there are some poor radiological prognostic sign. The clinical sign we simply can abbreviate into FOBS: female, older age, opacity, bilateral, and stiffness. And the radiological sign, they are listed there before. Interestingly, if you look at these, the poor radiological sign, you can see the lateral is common. There are many signs in the lateral aspect of the femoral head point to being poor. And that's what inspired Herring to come with the lateral column classification, in which he divided or he classified femoral Perthes disease into A, B, C, and BC, depending on how much of the lateral column has collapsed. With the group A, there's no collapse. Group B, there's a collapse, but less than 50%. In group C, the collapse is more than 50%. BC, the collapse is still around 50%, but the middle column is collapsed further than the lateral column. The thing we don't know whether these are classification or simply progression. We don't know whether type A will become type B, then BC or C, or genuine classes. This is for the classification of the severity. There are further classification about the outcome. When everything healed, how bad the hip is. And we have 3 classification: Moser classification, Stulberg classification, and modified Stulberg. Moser classification is simply by drawing a circles. These circles are 1 millimeter apart. And you see how much of the femoral head migrated from these circles. For example, here you can see 1, 2, 3, maybe 4 millimeter collapse. And here, what most propose, the outcome is good if the head remains spherical within 1 millimeter. Fair if it is 1 to 2 millimeter, and poor if it is if they become aspherical more than 2 millimeter. But we knew this might be extreme because the head can be collapsed more than 12 millimeter and still the hip function well. Stillberger classification came with the 3 important grades, which is spherical and congruent, aspherical and congruent, aspherical and incongruent. Within these 3 grades, there's 1 and 2, 3 and 4, and 5. In general, 1 and 2, they have no increased risk of arthritis. 3 and 4, they have mild to moderate risk of arthritis, while type 5, they usually have severe arthritis before the age of 5. And these are some pictures. This is type 2. Type 1 is normal, almost normal. You cannot differentiate it from normal. Type 2, type 3, type 4, and type 5. Well, type 5, you can see it is square, incongruent, and spherical. I just want to remind you, sorry, it goes to modified Stillberg. This is the Stillberg classification. Modified Stillberg, simply he ignored the subclasses and go for type 1B, C. But he got type C when the head is flat, type B when the head is oval or mushroom, and type A when the head is spherical. By simple demonstration by a graph, this is type A, which is spherical. This is the oval, and this is the flat. Just want to remind you with that Stillberg classification, believe it or not, we all caught it, but all based on 66 patients. So 66 patients divided by 5 grade or 5 classes, this is around like 12 patients each group. So treatment. What we know about Perthes disease is stage of death, collapse, and regeneration and healing. This is what Perthes described in 1930. Our understanding for it hasn't changed since then, almost over a century, but we haven't changed our understanding for it. Can we stop collapse? We don't know, but we think we can by using bisphosphonate. Can we speed healing? Again, we don't know, but we think BMB and other bone morphogenic proteins might help with that. Can we stop or influence the femoral head deformation? We think we can by doing containment or distraction. So how we do containment? Brace or cast, femoral osteotomy, pelvic osteotomy, combination of hip distractors. And these are how they started and when they were started. 1962, Salter started the first osteotomy for Perthes disease. 1965, the first varus femoral osteotomy. And 1966, where the pediatric cast and other broomstick cast started. So this is how we started the treatment 50 years ago. And interestingly, till now, after 60 years, we still treat it in the same way. I don't know whether we should be proud of that or not. I just want to remind you with another surgical procedure, probably was one of the commonest procedure we did in the 70s and 80s. We did surgery, vagotomy, pyloroplasty, gastrectomy, gastric bypass surgery for a condition we did not understand it at that time. But we better understood it when we understood in 1982 that actually this is infection and all these operations disappeared. And I hope one day we have the same for Perthes disease, because till now I don't think we understand it, how it happens, what the prognosis for it. But let's talk about what we know so far. So brace surgery is, there are different braces, there are different casts. Yeah, so you can't pick them. But for us surgeon, we always go for these options, femoral osteotomy, pelvic osteotomy, or both. Personally, I don't believe in pelvic osteotomy or combination for the reason I'm going to mention later, but I'm a femoral osteotomy guy. What's the indication? When is the timing? What technical tips? Outcome versus pelvic or combined, and personal thought. Indication, usually indication for femoral osteotomy based on the age, stage of the disease, and hip extrusion. There are different ways how to grade head extrusion. I'm not going to go into in detail for the sake of time, but Reimer migration index, bony acetabulum head index, cartilaginous acetabulum head index, sonographic femoral head extrusion. All these criteria are proposed to see how much migration is. You can read the references that I mentioned below. and all lead to the same message, which is how much of the head coming out of the socket. Okay. One thing I learned from this gentleman, Benjamin Joseph. Most of you know this gentleman. I listened to one of his lecture when I attended MUPOS meeting in 2019, and I bought into his philosophy about Perthes disease. And he has one of the biggest series of Perthes disease in the world, with over 600 plus patients of his own personal patient. So basically, he makes a cycle for Perthes. It started with the early vascular necrosis, stage 1A, which we mentioned earlier, then goes to stage 1B when the head starts collapsing, then 2A, 2B, to the end of the cycle. And this area here, the green area, the preventive intervention, if you're going to interfere, should be in this area here. And if the patient over 7 years of age, when the Perthes happen, do your osteotomy here. Don't wait for any classification, because if you do wait, it might be too late. If the patient under 7, simply you wash them until the head become extruded. If the head is not extruded, try to do varus osteotomy, ideally before you reach stage 2A or early fragmentation phase. And this is what came commonly known as early as possible and before 4 o'clock. According to his data, what he presented with 600 patients, when he applied this philosophy, like operate before the age of 7, after the age of 7 as early as possible, and before the age of 7 if there's extrusion, his result was he get the one that he operated on, 81% they have spherical head, in another way type A, versus 19%. While the one that not operated on, you can see how much difference. You have a lot of patients who remain in the spherical rather than irregular. So this is impressive result. It was not matched by any other results. So we go back to the, we talk about the time in the technical tip. Usually the study of the femoral head anatomy achieve good containment. These are the two important things. So what I usually do always, I screen them again in theater to see how much have neck shaft angle and how many rotation there. And I do to see how much good containment I achieve. And my plan, how many degrees of varus, how many degrees of interrotation, it is what give me a good containment. Some studies, like from Kim, he said 20 degrees of varus usually sufficient. I kind of disagree with that. To me, as good as I can. So even if it means that I will get to 90 degree, and I want these patients later in the future, once everything healed, we might need to do valgus osteotomy. More important for me is to get the head as spherical as possible. Some of you might disagree with this approach, but having treated many of these, I'm more convinced about this approach. Again, like for example, if you read the paper by Kim, he has 66 patients. He found no significant correlation between the postoperative neck shaft angle and Stulberg outcome for all the patients, apart from lateral pillar type B, where he found the higher postoperative neck shaft angle having greater probability of association with Stulberg type 1 or type 2, which again doesn't make sense. One paper I strongly recommend for people to read it is the Benjamin Joseph paper, How Does Femoral Varus Osteotomy Alter the Natural Evolution of Perthes Disease? Again, this is from his paper, which is the largest series. Of patients who were operated at the stage of vascular necrosis, 30% bypassed the stage of fragmentation. The duration of disease was shorter in these patients. The duration of the stage of the fragmentation was reduced in operating children who passed through the stage of fragmentation. Okay, and these are the classic papers that most people relate to them when they talk about pillar classification. The Wick paper and the Herring paper. Again, I'm not going to go through them because to me these are outdated now, and I don't think they help a lot. For example, the Perthes paper said Herring A, all ages all do well without treatment. Again, we know this is not very true, because some of Herring A, they can go into PNC and they do very badly. Herring B, if it is under 6, uniform outcome irrespective of the type of treatment. B, surgery, they do better than a brace and better than no treatment. B and C, again, surgery do better than a brace, better than no treatment. Herring C, all ages, poor outcome irrespective of the type of the treatment. I think I will stop here because this is about the late diseases. Thank you very much.
Thank you very much, Professor Sattar. It was really very nice, and I'm also convinced a lot with the varus osteotomy. He gets the best result. I don't like pelvic osteotomies too. Now we're gonna have the Professor Iftikhar Ahmed. We'll talk about early management of clubfoot. Dr. Iftikhar.
You are muted, sir. Dr. Iftikhar, you are muted, sir.
Unmute.
Yes, sir.
I
هسه
need
صوت
to.
اكو صوت هسه اكو صوت
Huh?
اكو صوت هسه نسمعك.
Best, I cannot let me see. Okay, wait.
No,
Can you hear me now?
Yes,
we
sir.
can.
Okay. Can I don't know how to.
دز لهم هم راح يسوي لك هذا داونلودينج.
Huh?
دز بالواتساب مثلا الى دكتور شوف مثلا
Yeah. So Iftikhar, there's a
Yes.
square bottom, green square bottom of the floor at the bottom. Can you see green?
The one over here.
مكتوب شير سكرين.
Yes, sir.
If you press on that
Green
button,
button down.
yeah,
And now?
in the middle, exactly in the middle. It is green with the arrow upward.
Yeah, I see that.
Professor Iftikhar, would you please open your presentation and then press on the green button down there written on it, share.
Yeah, I think we see your PowerPoint now. It's opening.
But I cannot see it. Okay.
زين تقدر تدزها للجماعة هم راح يسوي لك اياه.
Okay.
You can send your presentation to Professor Gamal Hosni and he will send it to me immediately, sir.
Sure.
هسه اسويها.
Okay.
ابعتها لي يا افتخار، ابعتها لي انا.
إن شاء الله.
ابعتها لي يا افتخار.
Yeah,
Okay.
guys, while we are waiting for Iftikhar to upload his presentation, guys, do you have any questions so far?
I have one question, Dr.
Please
Sattar.
fire away.
Yes. Do you know the problem now convincing a family that already the child have shortening, and when it virus osteotomy, there will be more shortening. It's very clear.
That's very good. Not just shortening, Las, because when you do the operation early for these children, two things will happen, and you have to warn parent about it. It's not the shortening, it's the fragmentation phase, which is more painful. So I tell the patient, we're going to do the surgery. Your child limbing is going to get worse, and the pain is going to get worse. This is natural part of the disease process. So the operation is not to improve the limbing. In fact, the limbing is going to get worse after the varus osteotomy because the leg becomes shorter and the abductor function will become even impaired. And the pain is going to get worse because the fragmentation phase is most. So when you warn people beforehand, they are more receptive to it.
Yes, Dr. Sattar. Yeah. Yes, this is the problem here that really this is a problematic disease, really. Whatever you do, sometimes you will not get the results you want. And the family always, they are complaining and blaming for the results. This is the point, because they don't understand the disease. This is so difficult. But the question, I use in the early case of Perthes disease, I use injection called ileomedin, which is ilioprost. It's a vasodilator. And I used this successfully in the very early cases with very good outcome. But on condition the child will get non-weight beating for about 6 weeks from the start of the treatment. And even use it with some cases that to really help the process. But why don't like to do salter osteotomy, for example? What's your idea about subject?
Ah,
I
very good
usually
question.
use pelvic osteotomy.
Yeah.
Yeah.
The
Okay.
reason why, because what we know about Salter osteotomy, it can give you up to 20 degrees lateral coverage and up to 15 degrees anterior coverage. And that's the maximum you get from Salter. Sometimes you need more than this for containment. You can do with the femur, you cannot do with Salter. The problem with the femur, why they don't like femur alone later in life, because the remodeling potential is low. But again, if you want parent, I said priority number one for me, I want to get containment, perfect containment. Because as far as we know at this stage, containment works if you get it perfect. And with Salter, you cannot achieve it. With femoral, you can achieve it, but you rely on the remodeling, and remodeling power, the older the child, the weaker remodeling power. So you've warned them beforehand. He said, I might do, once I finish, once the head fully healed, then we get reshape the thing. And people accept it if you tell them beforehand.
Yeah.
Thank you. Thank you, Professor.
I have
Yeah,
a rapid question. Do you agree that before the age of 7, we never need surgery?
I disagree with that.
Yes.
That's why I say these outdated. This is what Wig paper and the Herring paper said. Under 7, I do believe the philosophy of Benjamin Joseph. Under 7, you don't need surgery unless there's a subluxation. Once the subluxation is started, even if it is 5-year-old, I will think, because the subluxation is the beginning of the deforming force for the head. I will reduce it at that stage.
Yes. What I want to highlight is that if I have a young child as early as 4 or 5, we should have a very strict follow-up, because some cases may need containment too, as early as 5 years.
Yeah.
We just have to do good follow-up. The guarantee that below the age of 6 or 7 is have very good results with conservative treatment is not right at all in some cases.
Sure. What I did sometimes, Professor Hassan, some of these children, what I do, if I see, okay, they are stiff, they are thick, they start subluxing, sometimes I do what I admit them to the hospital for traction for a week, then adductor tenotomy, and put them in pediatric cast for 6 weeks for people who are really against surgery. So this you might salvage the situation. But as I said, if I see the head subluxing, I'll go for surgery.
Thank you.
Now, Iftikhar is back. Yeah. All yours, Iftikhar.
Dr. Iftikhar, you are muted, sir. Unmute yourself, please.
Okay.
Yes, sir.
Yes.
Is my screen is visible?
Yeah.
Yes, sir.
Yes. And your voice also.
Okay, thank you. Well, good evening, guys. I'm going to talk about early treatment of club feet. Well, the spectrum for the club feet is right from the birth right up to 10 years, sometimes even adolescent. So the deformity, let me see, okay, sorry, okay. So the deformity has a component of cavus, forefoot, a deduction, heel in varus and equinus, midfoot in supination. There are two serial casting procedures earlier were done. One was Kite and the other one Ponseti. Ponseti started his serial casting techniques in 50s, and with his technique was more practical, so he was able to achieve almost 90% success rate from the serial casting. Usually they would start at 7 days and last about 6 to 8 weeks. They are usually used in children even up to 10 years. Normally, this serial casting is done weekly, and knee is kept in flexion of 90 degree. And of course, the head of the talus is used as the fulcrum. Now, Ponseti had they concluded that there is a posteromedial retracting fibrosis, which is actually a thickening and shortening of the capsular ligament and tendons and sheets and so on that causes the pathology there. So if we, in one of his slides of pathology, you could see there is a severely medially displaced navicular with the wedge-shaped head of the talus and the navicular. Of course, there was also adducted and inverted calcaneum there, and also the wedge shape of the cuboid there. Now, in their series, Pirani did a series of MRI at first week of the serial casting, and they discovered the same findings with the medially tilted cuneiform with wedge-shaped talar head and inclination of the neck on the medial side. And in fifth week of the serial casting, they repeated the MRI serial. So there it suggested that there was well-reduced talonavicular joint and the shape of the naviculum was improved. Now, in another view, an sagittal view, you would see the calcaneum and the cuboid sitting on it is also medially displaced, whereas in the fifth week, they realized that the shape of the cuboid and the alignment of the hindfoot is improved in that post-serial casting. So what do we do in this technique of Ponseti? We use the talar head as the fulcrum and try to reduce the naviculum over the talar head. Now and then you apply a first cast. So the effective cast is the cast holds and retracts the fibrosis, retracting fibrosis that gets stretched. And after a week later, you will see there is loss of tensile strength of the medial contractures. Now, of course, second, the manipulation, again, you do sequential stretching and fibrosis get stretched, and the sequential improvement of the tarsal alignment and the shape. Now, it's very important to achieve a good results out of it or effective manipulation is that the child should be calm and either fed or pacifier is being given to him. So here the navicular is reducing under the talus, and after removal of the first cast, you will see there is a good position of the talonavicular joint. Plus, there is a tensility of the ligament is kind of reduced. Now, if the child is not cooperative or cranky or crying, your manipulation becomes ineffective. You try to reduce the head under the naviculum, and the child is moving and kind of crying. So tibialis posterior starts to pulling the navicular, again, opposite of what you are trying to do. And then with frustration, you apply the first cast thinking that you have done the right reduction. But when you do removal of the cast a week later and you see the effect is not as you expected. Now, the sequence of correction, of course, the cavus has to be corrected first by dorsiflexing the first ray and increase the supination. Foot looks worse, of course, but the forefoot abduction again has to be achieved by to correct the adduction, and the varus correction, hindfoot abduction corrects there. Finally, the equinus. Now, when the subtalar joint pronates, it corrects the varus and equinus simultaneously to some degrees. Now, it's very important that how you reduce it and where you put your fingers to maintain the position. So once you reduced the foot and the supination at the first cast, you need to move your foot, your hand, fingers a little bit proximally for the knee to hold the position. And while the thumb holding the talar head against that position is also moved so that the casting can be done by the technician. Now, it's very important that when you apply the cast, it should be below knee first, and then you manipulate and you supinate it, and you need to keep on moving the finger because first cast is the most important one because first metatarsal is lifted and this supination actually makes the basis of your remaining casting correction. So once you achieve the below knee cast in a good position, then you apply a cast above knee in about 90 degrees. You can put a slab, separate slab, and then so that you reduce the extra casting in the popliteal area. Of course, you need to make sure that the toes are visible to avoid any complication of those casts. Now, once you have done the casting, you need to get rid of this dead space there. By applying the left thumb in the plantar medial side of the first ray and the index finger on the dorsum of the talus there. And similarly, you do a right index finger, you can do the molding of the cast above the heel and try not to press anything on the heel so that it does not cause any pressure from the cast. Now, subsequent manipulations, of course, once you have achieved the supination, you just keep on abducting, doing the abduction in supination. And so here's the first cast. First cast is critical as it corrects the supination and align the forefoot. Now, we must not forget that hindfoot is still in equinus, so there's a good chance that it may slip. So 90 to 100 degrees of the flexion of the would help that. Now here is the young surgeon who did the Ponsati workshop. First cast was given by a surgeon and good looking cast according to him. After 4 days, the mother brings the cast without the child. It's either the technique is not done properly or molding is not proper. And also sometimes can be a cranky baby not allowing you to do that. So it's not uncommon finding to have the cast out. It's not embarrassment on the surgeon. So this is a third cast application, and the toes appears to be pale. So one must check out if there is external compression, or wait till the toes turn pink and undercorrect the cast if you require, or even redo the cast for in that case. Now, there are atypical club feet, of course. One has to recognize that there's a short great toe, hyperextended great toe there, deep creases medially and posteriorly, and rigid and chubby feet, of course. These chubby feet, sometimes there's a high chance of cast slippage, skin problems, even vascular issues are very common in these children. Now, we have to keep in mind that when we try to do the dorsiflexion, we should not try to break the midfoot, because once you break the midfoot, you end up having more complicated issues than this one. This is rocker bottom deformity, so we should avoid that, because then to correct this, you have to do a different kind of reverse Ponsati procedures there. Of course, one should always look for the Pirani score graph. It helps. It gives us guidance for the treatment. It's a three-dimensional deformity, as we know, the clubfoot. So it measures the deformity. There are 6 clinical signs which really present in every clubfoot. And it's a simple and a reproducible and reliable scoring system. Now, when you have persistent equinus and you are planning to do the tenotomy, one should really know that the lateral border of the foot is straighter, and at least abduction of the forefoot is around 40 to 50 degrees before you start doing the tenotomy. Of course, Pirani score graphs tells us roughly between 4th and 5th casting, you should try to do the tenotomy. Well, the indication for tenotomy is that hindfoot score should be less than 0.5, midfoot score should be less than 1, talar head 0, and abduction more than 60 degrees. Now, it's very important before you do tenotomy, you have to counsel the parents. Now, there are various ways you can do tenotomy. One of the way is to insert the blade from anterior and parallel to the tendon to avoid the injury of neurovascular bundle. Now, we must remember that in clubfoot, it's not always that the tendoachilles is in the center or the most posterior to the foot. It is usually laterally lying, so one has to keep that in mind. Of course, once you pass that, you rotate the blade, and you get the pop sound or sudden dorsiflexion of the foot. The other way you can do is percutaneous tenotomy, but tendon is lateral to midline. Now, you can do that in as an outpatient in clinic, and by local anesthesia, you can apply a patch of local anesthesia, and you can get that tenotomy done while the patient is in as an outpatient. Now, but the thing is, sometimes you can have incomplete tenotomy, and then the residual part of the deformity still persists. It prevents further correction because the tenotomy is incomplete. So in some of the patients, you can do forceps assisted tenotomy, especially those chubby and atypical feet where there are thick creases and posteriorly. So one has to do on the direct vision, so you can cut the right tendon in that way. Now, in younger infants, tenotomy achieves more than 15 degree of dorsiflexion, and then you need to put a cast about 3 weeks till the tendon heals. But in older infants, sometimes there is a restricted dorsiflexion. So for that purpose, you need to do weekly basis for 3 weeks till the tendon and achieve the dorsiflexion. Here is a child, a 3 weeks baby with idiopathic clubfoot. After the cast was removed, mother was horrified, refused the second casting. So it's very important that to follow the Ponseti method Bible, that, you know, there should be adequate cast padding, and don't indent cast near the tailor head because skin is very delicate there. Of course, once you apply braces for post-serial casting, you can again get this sore from the Velcros and not properly fitting braces. So one has to be cautious on that. So the take-home message is that do not rush to the cast directly. You manipulate the foot. You try to feel where are the indentations, where are the prominences, and then move the foot and see how much you can correct while examining the patient. And then you can start doing the realign the cavus, fulcrum of the head of the talus is used. And then similarly, forefoot is supinated and do the abduction after the supination. Thank you very much.
Dr. Hassan, you are muted.
Hassan, you are muted, sir.
Thank
Hello?
you. Iftikhar.
Yeah.
If there is any question concerning the management of clubfoot.
Professor Hassan, may I ask you just to postpone the questions to the end of the session, and then may I ask our dear speakers to answer the questions in the question and answer box and the chat box, because we have to stick to time, sir.
Okay, then we're going to have Professor Dr. Qinawi talking about neglected club feet.
Assalamu alaikum, kul aam wa antum bikhair. Thanks for the kind invitation. Thanks for Professor Gamal Hosni, my professors, and my colleague and friend, Dr. Sattar Al-Shaida. You can see my screen?
Yes.
Yeah. I'm Mohammed Qinawi, a consultant pediatric orthopedic surgeon working currently with Sattar at Al Ghayya Children's Hospital in Dubai. So my talk is about neglected clubfoot. And it's very controversial in the literature. What is the definition of neglected clubfoot? One of the definitions is untreated clubfoot until the age after which treatment, which is expected to produce successful deformity correction. Why we should treat clubfoot very early to avoid developmental delays, ambulation difficulties, and sure problems, fitting problems. However, the term neglected itself, it implies carelessness, which is not true, particularly in our communities where some families might be poor, might not have access to healthcare facilities and healthcare providers who would treat the clubfoot. And this is why we think that working age clubfoot is a more appropriate term, non-judgmental, and reflects the reality in developing countries. And the literature currently, any clubfoot which is not treated until the age of 1 year, it is considered a neglected or a working age clubfoot. What are the problems with working age clubfoot? The deformities are generally more severe, more complex, and stiffer because of the hypertrophied capsular tissues the muscular tenderness changes, particularly the hypertrophy and the HL and tibialis anterior medial structures, weaker stretched peroneum, which is a very important pathology as well. Bony changes, we know that, and those children, walking age children, the bones are mature, not cartilaginous like in infants. Bony deformities, secondary bony deformities, bony hypertrophy, particularly on the lateral side, the sites of impact. Skin changes like skin callosities, ulcers, and so on. What is the best treatment for walking age clubfoot? So still Ponseti method. According to the current literature, Ponseti casting should be the first line of treatment, regardless the severity or the age. We thought in the past that Ponseti treatment is inversely proportional to the age at the time of treatment. However, there is a very nice systematic review and meta-analysis published in 2018, and it showed clearly that Ponseti was used in 654 feet and children between the age of 1 year to up to 11 years. And children under the age of 3 years had a successful outcome in 88%, and above 3 years, 87%. So there is no significant difference between both groups. So older children get successful outcomes with Ponseti treatment exactly like younger children. And the this meta-analysis found no association between final outcome and the patient's age. Interestingly as well, the recurrence rate or relapse was about 18% in the pooled analysis, and the cast complications were about 7%. The goal of treatment, if we will use the Ponseti method and walking age children, is to get plantigrade feet rather than flexibility. So the main aim is plantigrade feet. What is the age limit of Ponseti casting in walking age clubfoot? You will find in the literature cases like that up to 16 years old with a successful outcome after casting, and then at the end tender Achilles, open tender Achilles Z lengthening. And you can find as well extremes like that, a 30-year-old woman treated with Ponseti casting, and this is her 22 months follow-up clinical pictures. There's a very nice paper as well published in 2020 about the Ponseti casting multi-center study in 429 feet in 15 hospitals and centers, 7 countries, including Egypt. Dr. Nariman Abou from Asyut was in this paper. So they have treated 49 feet and 303 patients, more than 1 year old. All of them are walking age, club feet, never had treatment before. And 9 of those patients, 9 of those children were older than 15 years. Excellent to good outcomes in 87%, 92% required tender Achilles lengthening. It was open 9% and percutaneous in 83%. Interestingly, 68% of the patients older than 9 years had percutaneous tender Achilles lengthening, not open tender Achilles lengthening. And 5% had tibialis anterior transfer with the tender Achilles lengthening as a prophylactic treatment to prevent relapses. And according to them, excellent and good outcomes are fully plantigrade feet with either 10 degrees, less than 10 degrees of ankle dorsiflexion and excellent, and 0 to 10 degrees ankle dorsiflexion and good outcomes. Relapses were observed in 31% of those feet which were followed up more than 2 years. And relapses were higher in patients actually below 4 years of age, which is in contrast to what we are thinking, that older children have more relapses. No, in this paper, younger children had more relapses than older children. And the main factors linked to relapses were poor compliance with braces. It was associated with relapses in 48% of cases. All 9 feet, which had A4 splint, not boots and bars or Dennis Brown splints, had relapses. No relapses were observed in 6 club feet, which had tibialis anterior transfer with a tender Achilles lengthening, and serial casting was used in the treatment of the relapses. 72% of the feet and 72% of the feet. What are the other options of treatment? We have open surgeries like extensive soft tissue release, extensive posterior medial release. However, we are not big fans now of extensive soft tissue releases in club feet because of the issues with infections, complications, deep scarring, muscle weakness, permanent foot stiffness. We have bony procedures, particularly in older children, like Evans procedure to shorten the lateral column, lumbar node arthrodesis, or strap arthrodesis. But again, they are very extensive, and fusions in children are not liked very much. We can do some minimally invasive interventions like soft tissue, tendon cage lengthenings, posterior release, plantar fascia release, medial release, bony lateral column shortening like Evans plus minus medial column lengthening. And there is a very good rule for external fixation in neglected clubfoot. I like particularly Elizabeth device in neglected or clubfoot in walking age in older children, not younger children. Some cases with club feet corrected by Elizabeth, we can do like the Ponce Taylor of the principal John Herzberg, to use it to just distract the soft tissues and correct it like a Ponseti method, or you can use osteotomies, like a V-shaped osteotomy, calcaneal osteotomy plus metatarsal osteotomy. And the V-shaped osteotomies, as you know, there are many types of them, mainly the calcaneal plus minus, another one, talocalcaneal or navicular cuboid or metatarsal. I like the calcaneal and metatarsal osteotomies as a V-shape. And then you can correct gradually until you get plantigrade corrected foot. And Elizarov, it is related, it's very versatile. So you can correct the heel independent of the midfoot and forefoot. So the heel varus, you can be corrected with a half ring posteriorly with the wires in the heel, and then you can correct the heel varus. The forefoot adductus will be corrected with the forefoot half ring or a full ring with the distraction medially. And usually we lengthen medially, and we don't shorten laterally because we need to lengthen the foot. So usually we leave the lateral threaded rod actually just loose. So it's mainly medial lengthening. And then one of the components, very important components, what we call the T component. The T component is basically a twisted 90 degrees twisted plate with two posts, two male and female posts, and they are connected to the foot half ring or full ring with two threaded rows. And this is crucial in order to correct the forefoot supination as well as the forefoot adduction. As you can see, so we do differential shortening of the threaded rows. Laterally, we shorten more than medially until we correct both supination, and we correct as well the adduction and the cavus. So all of them are corrected by the T component, which is very, very important. So Elizarov is very, very versatile, but we have another option, which is currently what we call the hexabots. So the hexabots, according to John Herzberg and the Baltimore group, below the age of 8 years, you can use the hexabot or what they call the Ponce Taylor method for soft tissue distractions. Above the age of 8 years, bony deformities, you need periarticular osteotomies according to them. So the Ponce Taylor, which was proposed by John Herzberg, has 3 stages. The first stage is to correct the rotation of the foot itself. So to correct the rotation of the foot, you need a full ring around the foot with wires in the mid-foot and wires, the calcaneus, and then a Taylor wire, but the Taylor wire will be fixed to the proximal ring, not to the distal moving ring. So it will fix the talus and will rotate the whole calcaneopedal block around the talus. It simulates, in order to simulate the Ponseti technique. So basically, in the first stage, you will fix the talus to the proximal ring, and the distal ring will rotate outside to correct the rotation of the foot and correct the rotation of the calcaneus underneath the talus. And then the second stage, once you have corrected the rotation of the foot, you need to correct the equinus. So you will disengage the Taylor wire from the proximal ring, and you will connect it to the distal ring. So it will be a single foot block, which is the talus plus the foot itself. And then you will correct the equinus at the level of the ankle joint. So this is the second stage of the Ponce Taylor technique. And then the third stage, according to them, if you have a residual forefoot adductus and varus, you can cut, as you can see, the ring itself around the foot, and you can correct threaded rows. And then you can distract the medial side to lengthen the medial column and shorten the lateral side to shorten the lateral column. We don't shorten the lateral column. Usually we only lengthen the medial column and just leave the lateral threaded row loose to have the correction of the forefoot abductus. However, we don't agree with the Bonsi-Taylor technique completely because it's like Kite's error. As you remember, if you remember the kite casting, the main disadvantage of kite casting is the fulcrum point. So the fulcrum should be around the tailor head, but according to Kite, the fulcrum was around the calcaneal head. And this stopped the calcaneus from rotating from underneath the talus in order to correct the hindfoot varus and the equinus as well. And this is the issue, because if you fix the calcaneus with wires in the Bonsi-Taylor technique, you are displacing the calcaneus, but you are not correcting the rotation of the calcaneus, the horizontal rotation of the calcaneus, because the calcaneus is horizontally rotated underneath the talus. So this is why we don't like the Bonsi-Taylor technique. And we came up in Manchester with our colleague, Dr. Farhan Ali, with another technique, is to fix the talus, tailor neck to the proximal ring, and only wires in the forefoot and midfoot. We don't put any wires in the hindfoot. And then this will be used, it's like exactly the Bonsetti, when you correct with abducting the foot and with the fulcrum and your thumb on the tailor head, and until we get the correction of the rotation of the foot. We're still waiting for some evidence, so we will get some CT scans to confirm that we have derotated the subtalar joint, but so far we don't have the evidence. But this is our idea. We don't agree with Bonsi-Taylor because we don't like calcaneal wires. We always put wires only in the midfoot and the forefoot, and Taylor wire to fix it to the proximal fragment and rotate the forefoot and the calcaneobedal segment around the talus, around the fulcrum, Taylor fulcrum. So another, if we will need a periarticular osteotomy, then we can use other forms of hexabos like the mitral frame. And as you can see, it is very complex. And as you can see on the right side, X-ray, you cannot see the foot. So you are correcting the foot according to your clinical decision-making and clinical judgment. But you don't see. It's very complicated, and we don't like it. You might simplify it with the butt frame, but with the butt frame, you need to correct the hind foot. So you need to correct, if there is equinus, you need to do posterior release. You can do calcaneal osteotomy, you fix it with the foot ring, the vertical foot ring, and then you will use the forefoot ring in order to correct the midfoot varus, abductus, and supination. Thank you.
Thank you very much, Professor.
Dr. Hassan, you are the next speaker, sir.
Yeah, thank you very much, Mohammed. Excellent lecture, really. Sorry, guys, for there's some technical issue. Next is Dr. Hassan Al-Berberi. He's going to talk to us about slip capital femoral epiphysis. All yours, Professor Hassan.
Thank you very much. It's glad being with you today. I'm going to talk about management of SCFE. It's well known that there is no place in SCFE for conservative treatment. The only way to deal with SCFE patient is either to do a pinning in situ or to do safe hip dislocation, or the so-called safe hip dislocation, and where we do open reduction and fixation after reduction of the slipped capital femoral head. In my institute, the main way of management such cases is to do pinning in situ for all stable cases. And unstable cases, we have both options, either to do pinning in situ also, or to do the open reduction and pinning. Just we have to discuss a few points before starting the technique of the fixation. We have to know that we only use one screw. One screw is more than enough. Besides, it's safer, and we don't need usually more than one. In unstable SCFE, we may add another screw if it's possible. Most of the cases, it's not easily done to have another screw. The second point is that we should always think about the ideal position of the screw. Pinning in situ is not so simple because you should have the pin or the screw in the center of the physeal head. It should be perpendicular in both the AP views and the lateral view. We have to bypass the physeal growth plate by 5 threads, and in the same time to be 5 millimeters away of the subchondral bone. We have to have these 5 points very clear in our minds. As I said, the screw should be perpendicular to the head. If it's done by a pediatric orthopedic surgeon, this is somehow clear in mind. But when the procedure is done by adult surgeon, which is very common, they're used to do fixation of the neck of the femur. And that's why the direction of the screw is completely different in the SCFE cases. They usually put the screw very low and try to put it in the exact position, which is impossible. That's why they should think in a different way. They should always think that this is not a fracture of the neck of the femur, and the starting point, the direction, is completely different from fractures of the neck of the femur. The only point where we can put the screw somehow oblique is in the severe slips, where it's also impossible to put it perpendicular, because at that time the screw will impinge with the acetabulum because the entry is so superior and anterior. Again, we should remember this is not a fracture. When you have a more severe slip, you go more anterior, and on the AP view, you go more proximal. Even you may go just below the greater trochanter. Again, the last thing that we have to discuss before discussing the technique, whether to do a capsulotomy or not. It's still controversial, although in unstable cases, the intracapsular pressure is high. It's not proved that doing a capsulotomy reduces the risk of AVN. However, some surgeons may use the capsulotomy in the reduction of unstable SCFEs. How do we do it? We have to think about 4 points. First, the position, the planning, the surgical technique, and the postoperative care. The position, we start with gentle transfer. We don't do any traction, no trial of reduction. The child is put in a supine position. We should put the limb in a slight external rotation position, which is the original position. We should not even try to do any tendency of internal rotation. All through doing the operation, we should not move the limb by any means. The C-arm should be moving. We should obtain a very good AP and lateral views. The problem with doing the SCFE is always that it's not so easy to have a good lateral view, except if you have a very good C-arm, which is not the condition in all of the hospitals in our country. I think this operation should be done with a very good image intensifier, because the lateral view is not so easy to have while doing the SCFE fixation. How do we put the screw? We should first think about the entry point, then the direction of the screw, then the length of the screw. Considering the entry point, we should have a plan before doing the operation. We look at the AP view. We take a perpendicular from the physeal plate in the AP view, and this gives us a point how high we should go at the entry point. It's not at the lesser trochanter, it's always above, and it would be as high as just below the tip of the greater trochanter. Also, going to the lateral view, we can know how we should go anterior, because if you see the fragment or the physeal head so much displaced posteriorly, you should go too much anterior to just catch it from an anterior entry. That's how we can plan it with an X-ray. Again, during the operation, we start with having a good AP and lateral view. We put a K-wire both on the AP and the lateral just to have an intersection. It's on the Y point here. And this Y point, the K wire should be overlying the neck of the femur and bisecting the head and perpendicular to the physis in both views. By getting the exact entry point, this is very crucial in starting the drilling or the entering the K wire. This is how we draw the lines. Then we start with a 2 centimeter incision, deep cut the iliotibial band. Some surgeons omit cutting the iliotibial band, which is very mandatory, because if it's not properly incised, the iliotibial band will hinder the rotating wire and even may cause it to bend. Then after entering with the K wire, sometimes it should be easier to make the entry point wider with a 4.5 millimeter drill bit, then inserting the wire with less hesitations, because some surgeons do multiple entries, weakening the lateral wall of the femur. This is not right. Then after inserting the K wire and checking it properly, we should have this wire again in the center of the epiphysis, perpendicular in both the AP and lateral views, 5 threads passing the physis, and no less than 5 millimeters away of the subchondral bone. It's easier to use a very long K wire, because when we insert the K wire, then we start drilling. While taking out the drill bit, we will have the wire back with us and we will lose the track. Having a long K wire facilitates this step too much. Then we should, after inserting the wire, use a drill bit, then a tab, which is very important, and then start inserting the screw after proper placement of the wire. Then the last step is how to be sure that the tip of the screw is in a proper position. We can use either a fluoroscopy in 20 increments to be sure that in every 20 degrees rotation, the screw is 5 millimeters away of the subchondral bone. Another way is to use the approach with root technique, while this is done after inserting the screw and releasing the limb from the fracture table. We can start with maximum internal rotation, rotating the limb to maximum external rotation. We will see the tip of the screw approaching the subchondral bone and the joint and then getting away. This is a very safe technique. If in doubt, just do a post-operative CT. We have to remember that transient pin tract penetration is harmless. Just the chondrolysis happens if there is persistent pin penetration. That's why, if in doubt, just we can have an post-operative CT, which we may do, and just get the screw 2 or 3 threads away of the joint. This is one of the cases with SCFE. It's a moderate one. Here you can see the screw in the AP properly seated, and in the lateral view, it's getting from anterior to posterior. Another case of SCFE where we did bilateral pinning. This is a severe case of SCFE, and here we inserted the screw, and we can keep something like 1 or 1.5 centimeters away to further insert more threads after 1 or 2 years. This is another case of renal failure where bilateral pinning was done. The post-operative care for stable SCFE is that we allow weight bearing with crutches as early as we can. And after 4 weeks, we can start normal walking. No contact sport until full physiodiasis is done. And we should do follow-up X-ray every 4 months. And if regrowth happens, which is the condition, especially in an 11 or 12 years old boy, the screw is advanced again after 1 year till complete episiodesis. To do contralateral hip fixation is only done if a child is below the age of 10 or if there is open dry radiate cartilage, or if there is endocrinal disorder like in hypothyroidism or renal failure. Continued growth after pin fixation is a modality done either with the proximally non-threaded screw or with the telescoping screw. We don't like both techniques. We use only the fully threaded screw and keep 1 or 1.5 centimeter outside the cortex and re-advance the screw after 1 year, which is more than enough. We should remember that the goal of the treatment is complete physeal growth. That's why there is no trial of removal of screw until complete ephysiodesis. We should always remember and inform the patient that removal of the screw is not as easy, even when we use fully threaded screws, because there is an instance of breaking of the screws while we try to remove them. We have to remember that there is no trial of reduction. We put the limb in slight external rotation. This is not a fracture, and the pin should pass by the center of the physeal head, perpendicular to the physis, both in the AP and lateral view. 5 threads past the physis and 5 millimeters away of the subchondral bone. We should do this operation in a very well-equipped hospital with a very good image intensifier. Never start the operation except after we see a very good lateral view in the lateral view of the child. Fully threaded screws is mandatory to facilitate the removal. We should use a long guide wire to make the drilling process easier. Don't start inserting the screw except after proper wire and checking both in the AP and lateral view. We should check the screw position with all of the modalities, the 20 degrees increments, the approach with the row technique, and we may need even to do a CT. In unstable SCFE, try to insert the second screw. Thank you very much.
Thank you very much, Professor Hassan. Excellent and rich talk. Please, Guy, use the question and answer to put any questions for Professor Hassan or any of the speaker. Our next speaker is Professor Mahmoud Mahran. He's going to look at different aspects of treating SCFE. All yours, Professor Mahran.
Can you all see the presentation?
Yeah, we see your presentation, but if you put it on slideshow, perfect.
Okay, thank you, Dr. Sattar, Dr. Muhammad Al-Ashhab, Dr. Gamal Hosni for inviting me to this lovely Ramadan evening. في أحلى إيه من إن الواحد يقعد with a bunch of professional pediatric orthopedic surgeons بعد صلاة العشاء في رمضان. This is a perfect evening. My name is Mahmoud Mahrana. I'm a professor of pediatric orthopedic from Ain Shams University, and the presentation was prepared by me and my colleague doing the research work on slip capital femoral epiphysis, Dr. Mustafa Baraka. Actually, the slip capital femoral epiphysis, despite it's a very common entity that a pediatric surgeon would face, but it has been a continuous source of arguments and debate between all colleagues working in the field. And some of the aspects of my presentation are only related to my understanding according to the experience in alignment with the available literature. So دكتور حسن كان المفروض ان هو هيتكلم عن الستيبل سليب كابيتال فيمورال ابيفيسيس، وانا هتكلم عن الانستيبل سليب كابيتال فيمورال ابيفيسيس. بس دكتور حسن طبعا هو براحته يعمل اللي هو عاوزه، حبيب قلبي، هو اتكلم على البيننج انسايت. فانا I'll try to go through the lecture discussing something about the stable and my understanding and experience about the unstable variant. If we see these two cases can present as an unstable slip capital femoral epiphysis. Although this X-ray shows obvious instability, but the second X-ray, despite what can be presented as a clinical instability, but the X-ray looks like a device is closing. So why this patient is coming with pain, with inability to weight bearing? Should I consider this an unstable too? we'll go through this. So the objective of this talk, I need to talk about what we really know about the slip capital femoral epiphysis. What are we sure of about slip capital femoral epiphysis? And we need to discuss the concept of instability and discuss the early treatment option for the unstable variant of slip capital femoral epiphysis and the subsequent management, because it's not about management of the unstable type and leaving the patient, because it will never end in a good way in most cases. So what do we know? We know that slip capital femoral epiphysis has diverse mode of presentations. And we know also that slips can progress. So we can have an unstable slip capital femoral epiphysis and a stable variant that could be mild, moderate, and severe. If a patient is presented with mild slip capital femoral epiphysis, we know it can progress to moderate and severe. So whenever you see a case of slip capital femoral epiphysis, whether it's stable and unstable, at the time you see the patient, do expect that there is high incidence of progression. So, and this makes pinning in situ, like Dr. Hassan has showed us, the most important procedure in slip capital femoral epiphysis. We know also that instability has been defined as a clinical diagnosis, which is inability to weight bear even with crutches. But sometimes inability to weight bear could be due to pain. So we need to ask ourselves, what will be the causes of pain in a patient with a stable sleep? Can a patient with stable sleep presented with inability to weight bear? We'll get to that in a minute. So it's not always about the clinical instability. Sometimes we see the X-ray and we say that there is radiographic instability, such as if we have a clear head metaphyseal separation or gross angulation in the absence of metaphyseal remodeling. Another issue that has been described by Zebra in 2012 is the intraoperative stability, because sometimes you go in and do a surgical hip dislocation for a slip that you have thought that it's unstable or stable, and you find that intraoperatively the slip is really unstable. So that's the importance of intraoperative stability. So it's not about the clinical instability only. Sometimes you need to suspect the instability by the X-ray, and then the final check for the instability is intraoperative if you have to go in and open, and we'll get to that. What do we know also? It's a fact that AVN is the most dreadful complication of slip capital femoral epiphysis. And when all the factors related to AVN were discussed, whether sleep stability, sleep degree, or treatment timing, or treatment method, only the instability or the stability is related to the AVN. So having an unstable slip capital femoral epiphysis means that we have an instance of AVN that could approach 50% in average 50% in the published literature. What do we know also? We know also that slip capital femoral epiphysis is a precursor, causes femoroacetabular impingement, and this is a definite precursor for hip osteoarthritis. So we start with a slip and end with a pistol grip deformity, and definitely this end in arthritis. And why this happens? Because we have labral injuries associated with the impingement, and we have chondrolabral injuries, and all these are prerequisites for the occurrence of osteoarthritis. So it's not about stabilizing only the slip by in situ pinning. You need to think long-term that the MPN or avoid the AVN, and then on the long term, we need to prevent the osteoarthritis by treating the residual femoroacetabular impingement. So for the unstable slip capital femoral epiphysis, what is the best treatment option? Is it closed reduction and pinning? Is it pinning in situ without reduction? Or is it open reduction by modified Dunn's procedure? All the options are discussed in the literature, but any recommendation for the treatment of the unstable variant is at best a level 4 and mostly level 5 evidence. And this gives me the right to discuss my own personal experience and my own preference in these cases, disregarding what could be a disagreement in the literature. So what do we know also in slip capital femoral epiphysis? For both the stable and the unstable variant, The most accepted treatment method is pinning in situ, and in most cases, pinning in situ alone cannot or does not guarantee a satisfactory long-term outcome, and this is the management of slip capital femoral epiphysis in the hip impingement era. You cannot do pinning and leave the patient as it is. So what about the surgical hip dislocation and subcapital realignment? First, if you are against this procedure, know that AVN is related to the instability and not the treatment method. And this has been published thoroughly in the literature. The second reason that we go for this is that genuine unstable slip capital femoral epiphysis is rare, because usually most of the cases, over 90% of cases, usually there is a posterior callus. So what we regard as unstable could be an acute traumatic episode on top of an old slip, or it could be a stable slip and pain actually is due to the synovitis from the impingement. So not every unstable, not every case of slip capital femoral epiphysis that comes with pain and inability to weight bear could be unstable. It could be a stable, and the causes of pain could be a synovitis or other causes of pain from femoral acetabular impingement. What about the AVN? AVN occurs due to the tamponade effect from hemoarthrosis and effusion, and due to vessel kinking, such as the acute displacement and callus stretch due to unintended reduction. While in fact, subcapital realignment by surgical hip dislocation will avoid all this stuff. When you do a subcapital realignment, you unkink the vessel, you decompress the hematoma, and you remove the posterior callus that's present in most of the cases. So you are protecting the vascularity, you are using the physeal instability and mobility to facilitate a forceless reduction, and you give the patient the chance of perfect anatomical realignment. And if you compare open reduction versus in situ pinning, there is no evidence to support open reduction over in situ pinning. Dislocation, surgical hip dislocation, should be adopted with caution only in this dedicated center, and we insist that you should have a good experience in good number of cases to do this procedure. Okay, but if you don't have experience and you want to play it safe, you are totally free to go for the safer approach, doing in situ pinning without reduction, but this is not the end. You have to later assess the severity of the deformity and deal with the residual proximal femoral deformity to manage the case and avoid the long-term outcome. The Perthes method has been published, and it depends on just forceless open reduction through an anterior approach to evacuate the endovascular hematoma and effect slight reduction to downgrade the degree of slippage. And in the original article, the AVN rate was 4.6%, which is okay. But pooled analysis recently declared that the AVN rate is actually 9.9%. So to sum up this, pinning for the unstable subcapital femoral epiphysis, it should be urgent or emergent within 24 or 48 hours. Reduction should be incidental, just gentle manipulation with the positioning on the operation table, just to downgrade the slip from severe to moderate or from moderate to mild. Fixation with single screw. Capsular decompression should be performed or not. We don't know. If you can do it, do it. If you don't want to do it, there is no evidence to suggest either one of them. And again, any recommendation is at best a level 4 or level 5 evidence. And this recent meta-analysis in 2022 for the unstable slips discussed all the available options in the literature. And with the Perthes method, the incidence of EN was the lowest, that was 9.9%. If we see pinning in situ was 18.5, and that was the same as subcapital osteotomy via the anterolateral approach and the modified done, nearly the same, with no statistically significant difference between pinning in situ and subcapital realignment, which is aligned with our protocol of management. So the summary of this meta-analysis, AVN rate in situ pinning lower than closed reduction. So you shouldn't attempt reduction by any means. Intentional reduction by the closed method and the severity of the slip are risk factor for the AVN. It's not about the surgical procedure that you do. prevalence of AVN for the Perthes method was found to be the lowest, but maybe because the cases that Perthes presented was rather mild to moderate cases, not moderate to severe cases. And so the modified Dunn has the advantage of meticulously preserving the preosteal blood supply with no more instance of AVN than in situ pinning. So avoid closed reduction, avoid traction table, only incidental reduction with in situ pinning, open reduction modified Dunn indicated center. If you have an experience in this, mini open reduction may offer a lower AVN rate only in mild to moderate slips. What about the subsequent treatment? Now you did pinning in situ or subcapital realignment. If you do subcapital realignment, you have abolished the deformity and the patient now doesn't have to suffer femoroacetabular impingement. If you do pinning in situ for a moderate case or a severe case, then you have a residual deformity and residual femoroacetabular impingement. So you need to assess the severity of the slip by the Southwick angle method. So you frog lateral view, subtract from the normal side. And if you have bilateral slip, you resort to a normal angle of 20 and you grade it mild, moderate, severe, less than 30, 30 to 50 and greater than 50 degrees. And then if you have a mild case of slipped capital femoral, now that is stabilized after pinning, it can be impingement, it can be not impingement. If you have a moderate or severe case, always it is impingement. And we have two types of impingement in these cases, an impaction type and an inclusion type. And this is very important to differentiate because it will affect the decision and the chosen surgical procedure for this. So our protocol, if you have a stable, now stable because you have already done pinning in situ and the mild slip capital femoral epiphysis, you check for clinical impingement by hip flexion less than or equal 90 degrees or internal rotation less than or equal 15 degrees. If the mild slip is non-impingement, no further treatment is needed. Where if it is impingement, you have to relieve the femoroacetabular impingement by osteochondroplasty. You can do that by hip arthroscopy, mini open approach, or by surgical hip dislocation, whatever you are comfortable with. But if you have a stable and moderate and severe slipped capital femoral epiphysis, it is always symptomatic, it is always impinging. You need to assess the physodesis or the physeal maturity by a CT scan and the X-ray. If you have an open physis, this is different from having a closed physis, because in both cases, you need to relieve the femoral acetabular impingement. And if you do that by a modified Dunn procedure, in open physis, it's easy with lower risk of AVN. While if the physis is closed, there is high risk of AVN because it now becomes a cuneiform osteotomy or neck osteotomy rather than a subcapital realignment. And then how to relieve the phi in these cases? We do osteochondroplasty alone, alone relieve the impaction impingement, but doesn't relieve the inclusion impingement. If you do intratrochanteric osteotomy, it relieves the impaction impingement, but doesn't relieve the inclusion impingement. So in these cases, where we can't do subcapital realignment due to physeal stability and healing, we do osteochondroplasty plus intratrochanteric osteotomy to relieve both the impaction and the inclusion impingement. We have already published these, osteochondroplasty plus modified Imhauser osteotomy through the surgical hip dislocation approach. This is the case of 11 years old girl presented with unstable slip clinically and radiologically. It's very evident. We choose to do open reduction through surgical hip dislocation because the instance of AVN in this case will depend on the instability rather than the surgical hip dislocation. So we did a modified Dunn procedure. Then we do initial documentation of perfusion, extended retinacular flaps. We mobilize the epiphysis very carefully, preserving the blood supply, and then we remove the posterior callus. We don't do neck shortening, rather than trimming of the neck, remove the posterior callus to do easy realignment. This is very important. And in most cases, we find there is always a posterior callus that stretch the vessel and need to be removed. Because if you remove this and you do easy and non-forced realignment, you avoid the vessel compression and kinking, and that's it. Always avoid the closed reduction maneuver, reduction without tension on the retinaculum, femoral head perfusion recheck, and then we go for fixation. This is a 2 years follow-up with perfectly preserved hip with no femoral head AVN. But you can do this and you get an EVN. Don't blame yourself. You blame the instability that happened. And this is the follow-up after 2 years with good range of motion. Of course, she have some coxavara that resulting in some residual Trendelenburg gait. So the take-home message, and we have published this in the SICO journal, we published this, what we call the N-Champs organism. If we have an unstable slip capital femoral epiphysis, whether this is clinically as inability to weight bear or radiologically because of well-formed radiological demarcation between the epiphysis and the neck, then we go for subcapital realignment by surgical hip dislocation, because we believe that this stabilized devices and avoid the proximal femoral deformity and the long-term consequences. Okay, if you don't have experience in this, or if you are not happy with the subcapital realignment, do in situ pinning to stabilize and then wait. Later, assess the severity of the slip after stabilization. If it is mild, then you have to check. Is it impinging or non-impinging? If it is impinging, you have to do an osteochondroplasty to avoid hip degenerative changes on the long term. If it is non-impingement, that's it. So it's in situ pinning and that's it. If you have a moderate to severe slip capital femoral epiphysis that you have stabilized by in situ pinning and the patient survived without AVN, then you have to do a modified Imhauser procedure plus osteochondroplasty to relieve the inclusion and the impaction impingement. Thank you very much.
Professor Hassan, you are muted, sir.
Thank you very much, Mahmoud. Very, very nice presentation.
And thanks for all our speaker guys. Really excellent talk from everyone. My plea for all this delegate, please put your questions for all the speakers in the question and answer. And also my plea for all panelists, please, even if it's not your talk, if you have important message, please, you can reply. It is not a monopoly for the speaker. This will enrich all the discussion. Now, I'm so sorry we are overrun with this session, but I'll pass it to my colleague, Professor Saleh and Professor Saleh and Professor Mustafa Sherbini for the next and the last session.
Thank you so much, sir. Thank you, sir.
Good evening.
Please, at the end of the second session, I would like to thank our dear speakers, Professor Sattar Sharidia, Professor Iftikhar Ahmed, Professor Mohammed Knawi, Professor Hassan al-Barbari, and Professor Mahmoud Mahran. The third session, it contains 3 speakers and will be moderated by Professor Saleh al-Saifi and Professor Mustafa Sherbini. Professor Mustafa, please.
Assalamu alaikum. مساء الخير. The last session will started by Dr. Saleh al-Saifi. We will discuss the flat feet. Please begin, Dr. Saleh.
Thank you very much, Prof. مصطفى. السلام عليكم. مساء الخير عليكم جميعا وتقبل طاعتكم وكل عام وانتم بخير. بس لو تكرم دكتور, I try to share the slides if you can allow me to do so.
You can share it, sir. There's no problem with sharing.
Can you see my background? Because
no.
I think you should give me an access.
You are a co-host, sir, so you can share it.
It doesn't allow me actually on the screen here. I don't have the icon actually to share. I'm not sure where it is. Oh, here you go. Just wait a second. Sorry, my bad.
Yes, sir. Yes, sir.
I think now you can see my screen. Yeah. So again, good evening to everyone. It's midnight, I think, now here in Kuwait, and it's 1 p.m. Past midnight in Dubai. So I'll try to be quick through the lectures, and part of the lectures will be completed by Dr. Mohammed Abdel-Al after me. So we'll be talking about the flexible flat feet in children. How do we understand it? How do we approach it and treat it? And if we consider surgical treatment, how do we plan this? So by definition, flat feet is when we have a collapsed arch when somebody standing from our kids. And it's usually common in kids, and most of our private or governmental patients visit are concerned about families concerned about their feet, their kids' feet, and they have a fear of developing this flat feet condition. And this is something that everybody love to label people here in the Middle East, like you do have a flat feet and you need to have a treatment, and then everybody has his own input, and nothing usually works with those, and so people usually tend to present and seek the medical advice. So the main differentiation in flat feet is considering those flat feet to be flexible versus being rigid. So probably it accounts again to the most common deformity that comes to the pediatric orthopedist. And the parents are usually concerned about the abnormalities and the deformity, and they are worried about the flexibility of the flat feet if they think it's normal foot variation. So Stahili said earlier, long time ago, that flat feet are usually part of the infant, but it's common in kids and within the normal range in adult. And this is actually most of it. And if you look into the literature, 25% of the kids' flexible flat feet move to the adult side without any problems. And this is what I tell families usually, like flat feet is a description, is not a disease unless it causes a trouble to the foot. So again, the clinical examination is something that we all know. You have to examine the patient's gait in the clinic. You ask the patient to walk back and forth in the clinic, and then you ask him to heel gait and tiptoes to assess the hindfoot flexibility and the arch of the feet. And then you also check the foot in terms of inspection for callosities and harder skins, patches. And you also inspect as well the shoes, because they indicates the type of deformity you have. And if the shoe wear happens quickly, you actually facing, I would say, something like an advanced flat feet. Then the radiological assessment is usually by taking the child to the radiological suite and taking a weight-bearing AP laterals, and you also have to check the obliques to rule out any abnormal bony connections. The most reliable angles that we rely on in terms of a flat feet is meeting the measurement of the Mary's angle and Kite's angle as well. So flexible flat feet functionally as a normal flat functions at normal flat feet with arch. If there is no shortening in the Achilles tendon, and the rigid deformity always has to be excluded. So do we treat them? Usually we don't. We just have to observe. If it's usually asymptomatic in the younger age group. It rarely affects the shoe wear, and cosmetically concern of the family is always there, but you have to rule out other causes, and you have to examine for ligamentous laxity, because the foot at this stage is still in its developing stage. So how do we treat them? We need to reassure the family. We need to encourage the bare weighting, barefoot walking activities, good shoes. I wouldn't say soft shoes. Good shoes is something that has a good arch support inside the shoes, good cup, and good heel touch on the floor. So if you look into the literature, in 1989, an article was published studying the differences between putting in insoles or shoe modifications. And they looked into 4 groups, a control group and corrective orthopedic shoes, third group who were treated with Helfet heel cup, and a 4th group which was treated with a molded cast. The conclusion after treating those kids for a good time of I think 3 years, minimum of 3 years, showed that there is a very minimal wearing corrective shoes. After wearing the corrective shoes, there was a very minimal changes, and it doesn't influence anything in those growing feet. So could it be hurting, or could it be affecting anything else? Another study showed that a footprint of 2,300 children between the age of 4 to 13 had the incident of 8.6 among the children who were using footwear, compared to 2.8 on those who did not, which means there is no significant improvement if you wear shoe modification. Also, another article studied the psychosocial development and corrective shoe wear used in children with the flat feet. And they looked into that those kids do have a lower self-esteem. Some of them have decreased self-image and negative experience, and they were teased by other kids in school. And they do have actually activity limitation. Other studies also looked into the effect of those flat feet on the health-related quality of life, and they found that those kids usually try to avoid activities if they do have flat feet, which is fine. You can support them, you can encourage them, you can support their feet to move in and about. And another study here at the bottom of the slide shows that kids with symptomatic flat feet are actually having a lack position joint energy for propulsion. So they do have a problem with the push when they walk. And the other kids with the asymptomatic flat feet, they needed to have and absorb more negative ankle joint energy during loading. So if we move to the next age group, which is the 6 years old onward, do they need treatment? Again, it depends on the experience of pain and fatigability, the possible shoe wear problems if they do have any, and if they do have tender Achilles tightness, which actually counts to pain. Again, we recommend same exercises as the other group, but we add stretching to the Achilles tendon, physical therapy as well, and insoles if it's not painful, because usually kids with flexible flat feet and tight tender Achilles will have pain if you actually raise their medial arch. So generally, the research shows no significant long-term effect if you wear shoe wear or shoe insoles, and the corrective insoles doesn't really alter the shape of the feet. So when do we consider surgeries? We do consider surgeries if the feet actually comes out of its norms. So a normal feet should be painless, plantigrade, and shoeable or braceable. But if any of those three factors is lost, we need to think about moving towards surgical correction. So moderate and severe cases with persistent pain should need surgery. If the non-operative treatment doesn't really work, and if a severe flat foot with functional impairment, here you actually need to consider I would say, the flexible flat feet surgical intervention. So what are they? Most of them are accounts, or they go between the arthroresis or the stopper screw of the calcaneus, the lateral column lengthening, and the medialization of the hind foot at the calcaneus level. So what is the subtalar? I think Dr. Mohammed Abdel will be going into better details than me here, because we actually had to kind of organize those two lectures. So subtalar arthroresis is when you insert a polyethylene peg into the subtalar joint. It could be a peg, or it could be a plug into the sinus tarsi. The literature shows some satisfactory results. I am not a big fan of subtalar arthroresis. The complication rate is 5 to 19%. There's a lot of concern about the position within the sinus tarsi, the lysis, and erosion at the bone and the implant migration. The calcaneal block screw or stop screw is introduced by Pisani and popularized by Pellegrini. They had actually a good number of cases that is being studied, and they reported good results in 94% of cases with the clinical aspect and good X-ray measurement and absence of complication. But they do also report about 6% of complications, especially on those feet with a contracture at the peroneal muscles, and which is actually the antalgic for the position. The calcaneal stop screw depends on mainly two factors. It is related to the body weight. So the bigger the body weight, the less the successful the result. And the age of the kids, it is better to be done between the age of 9 and 12. The concerns here is peroneal spasticity, Achilles tendon tightness, and insufficiency correction of the age group. Calcaneal lengthening osteotomy is actually introduced by Evans, and it is really loved osteotomy by Mosca. It is done by doing an osteotomy and lengthening the lateral column between the medial and anterior facet, the middle and anterior facet of the calcaneus, plus minus lengthening the tendo Achilles peronei, medial column cuneiform osteotomy, medial soft tissue plication, and the whole package that we all know. I love this surgery. I only do it if a child is really indicated. It comes with a good outcome. The family usually are very happy. But literature showed as well that, the result is satisfactory in clinical and radiological correction of all components of the deformity if you do a calcaneal lengthening. There's a few concerns with the calcaneal lengthening is when you have a calcaneal cuboid subluxation, that's where you have to put a wire when you actually, before distracting the osteotomy. And it's a bigger surgery because it's a big surgery on the foot. It takes 6 weeks of casting and usually use an autograft or allograft. I actually use an allograft, which is a very nice block that I use, and it actually stays for a good time. Medial displacement osteotomy of the calcaneus is also there as an option for flexible flat feet. I don't do this much unless it's indicated. And in our practice, what we would do usually is we do not do any surgical intervention unless there is a real indication and there is a real reality of pain with a proper assessment and functional impairment. The family education is also very important to know the natural history of the condition, and you have to bring them in for a good discussion because these are painless feet usually, and you don't want to turn those painless feet into a painful feet. And you also have to think about good foot support and comfort. You need to consider the other causes of pain on the feet. So you have to think about the neurological issues, and you need to think about doing a proper conservative management before moving into surgery, and patient education is the key. So as a conclusion, most of our cases of the flexible flat feet usually resolve naturally without any intervention. Treatment is only for those symptomatic feet, including painful feet, not those feet without a very good plantigrade position, and non-braceable feet. Surgery it should be only reserved for those severe cases, and awareness needed for psychological impact. Thank you very much, and I will put the microphone back to Dr. Mustafa, and they will take the questions at the end.
Thank you. The question will be at the end. Now, the second speaker will be Dr. Mohammed Abdelal, my colleague in National Institute of Neuromotor System, and he can begin now.
Okay, thank you, Professor Mustafa, and I would like to thank Professor Gamal and Professor Sattar and Professor Mohammed Asha for this opportunity. Okay, I try to share my presentation. Yes. Okay. Okay, shared. It's okay. Okay.
It's okay, Dr. Mohammed.
Okay, it's okay. Okay, I can start. Okay.
Yes.
Today I will talk about lateral column lengthening in flexible flat foot. The flat foot involves three-dimensional deformity with loss of the longitudinal arch, height, hind foot valgus, forefoot, and forefoot abduction. There's problem in what's happening. Okay, surgical treatment is aimed at relieving patient symptom by realigning the foot to improve foot kinematic during the gait cycle and reduce the possibility of degenerative changes in the hind foot and midfoot. Lateral column lengthening, as described by Evans and modified by Mosca, remain most interesting option in children as it allows further growth and doesn't involve arthrodesis. The systematic search in electronic database result in more than 340 articles about lateral column lengthening, but it is not possible to carry out meta-analysis by Tiago despite this huge number of articles for one procedure. Why? Because there's subjective criteria, there are different surgical technique, heterogeneity of radiological parameter, and different implants and different graft used in lateral column lengthening. So lateral column lengthening has many controversies, from the approach about the direction of the osteotomy, shape of the graft, type of the graft, and joint, calcaneocuboid joint stabilization and fixation on type of the fixations. The approach, there is oblique incision and longitudinal incision. The oblique incision provide good visualization of the surgical site, minimize scar formation, but there is a high risk of transecting the sural nerve and peroneal tendon. The longitudinal incision provide more exposure for fixation, decrease the risk of sural nerve, but with thick scar postoperatively. What about the direction of the osteotomy? Actually, the osteotomy started 1 to 1.5 centimeter proximal to calcaneocuboid joint and directed toward a point either between the anterior and the middle facet, or to a point between the middle and the posterior facet. When the osteotomy exits between the anterior and the middle facet, it's called Evans osteotomy. The Evans osteotomy have the advantage of lateral to the center of rotation. Actually, the exit of the osteotomy in Evans osteotomy is lateral to the center of rotation, which is located on the head of the talus. So the osteotomy in the Evans should be complete osteotomy to the medial cortex of the calcaneus. If the osteotomy directed to between the middle facet and the posterior facet, so it's called Hintermann osteotomy. The Hintermann osteotomy had the advantage near the center of rotation because the center of rotation in the head of the talus is just above the syncytium tali. So it's osteotomy in Hintermann may be incomplete osteotomy and make a hinge on the medial cortex of the calcaneus. So there's 3 types of the facet of the calcaneus according to Burling classifications. Actually, this is image can be applied in intraoperative, but can be obtained by 10-degree plantar flexion and anterior view by imaging. This can apply the location of the facet on the X-ray. On the anterior tubercle, the anterior facet, and the sticulum applied the middle facet, and there is a curve between the middle and the posterior facet. So the direction of the osteotomy should be between these 2 facets. This surgical technique by applying pin in the anterior tubercle and another pin on the level of the syncytium tali, and the osteotomy is directed toward the point between the middle and the anterior facet. And do distraction by Hintermann distractor or any other type of distractor. Now the osteotomy is distracted and filled with graft. So what shape of the graft I can fill the osteotomy? Wedge graft, trapezoidal graft, or rectangular graft? Actually, the effect of the graft shape for lateral column lengthening on the amount of deformity correction and foot biomechanics is still unclear. And the exact mechanism by which the lateral column lengthening corrects the foot position is not fully understood till now. At the beginning, Evans suggested that it should be possible to improve foot shape of the foot by lengthening the lateral column by opening wedge osteotomy of the calcaneus. He noticed that the valgus forefoot deviation disappear with the navicular moving medially in the talus, also restoring the more cavus of the midfoot. After that, Mosca modified the Evans procedure. He based his operative technique on observation, just observation, that the center of rotation of the correction is near the talar head and not simply the medial calcaneal cortex. Thus, the osteotomy was trapezoidal shape, filled with trapezoidal shaped graft. Also in 1995, Mosca suggested that the plantar fascia act as one less mechanism to elevate the arch by using trapezoidal shaped graft. But after 3 years, in 1998, Horton disproved the theory. He reported that plantar fascia loosen in lateral column lengthening when using trapezoidal shaped graft. So Dumontet described the 3-dimensional bony relationship with the lateral column lengthening, and he found that the effective center of rotation of the navicular was within the head of the talus, and the cuboid was within the calcaneus. So then he reported that the navicular and the cuboid rotate in adduction, pronation, and translated medially and plantarly on the head of the talus. And the cuboid and the navicular appear to move as a unit, as a one unit in the correction of deformity. After that, Kent found that after lateral column lengthening using trapezoidal shaped graft, the lateral 1/3 of long plantar ligament is under maximum strain, but the medial 2/3 of the ligament decrease in tension to point wrinkle the ligament. Also, the medial band of the plantar fascia was lax when using trapezoidal shaped graft for lateral column lengthening. So after that, Campbell in a biomechanical study compared 10 millimeter trapezoidal graft with 10 millimeter rectangular shaped graft. He reported better bony alignment with the rectangular and identified decreased navicular contact pressure. Also, who in a biomechanical study, another biomechanical study in 2022, he reported better bony alignment with the rectangular shaped graft and identified decreased calcaneocuboid contact pressure, which will decrease the lateral side pain accompanied by the lateral column lengthening and decrease the risk of calcaneocuboid arthrosis and arthritis. So the rectangular shaped graft increased the distraction volume medially in the calcaneus osteotomy, which increased the distraction near the effective center of rotation of the navicular within the head of the talus, and also increase the tension in the whole long plantar ligament, not only the lateral 1/3 as with the trapezoidal shaped graft. So now there is a comeback for the rule of the windlass mechanism in the correction of deformity, but this time with long plantar ligament, not the plantar fascia as Mosca described. So the bony architecture and the long plantar ligament and possibly the plantar talonavicular capsule appear to contribute to the mechanism of deformity correction in the flat foot. So what about the calcaneocuboid joint stabilizations? Actually, as we described, as we said before, that the cuboid and navicular appear to move as a unit. So it's unlogic to block the calcaneocuboid joint by K-wire before the osteotomy. So it is of maximum importance to maintain dorsal and plantar ligament of the calcaneocuboid joint to maintain stabilization of the calcaneocuboid joint and prevent the dislocation of the calcaneocuboid joint with distraction of the osteotomy. What the type of the graft we can use? We can use allograft, you can use autograft, iliac autograft, we can use autograft fibular graft. Actually, the fibula can be easily used as a rectangular shaped graft. And the surgical technique, extraction fibula, and then fix. And these are our articles with Professor Kamal Hosni and Professor Khalid Zaghloul about using rectangular shaped graft in correction of lateral column lengthening. So there's many types, also other types of the graft like titanium wedge, like interpositioning blade, and the big cage also can be used in the as the graft. And this is a surgical technique using the calcaneal lumbar cage at a graft instead of the autograft or the allograft. And this is our upcoming search, which will be published soon. Despite all of this, lateral column lengthening has a good clinical and radiological results with high patient satisfaction and acceptable level of complication. Thank you.
Thank you, Dr. Mohammed Abdel. Is the screen it's clear now? Dr.
Yes,
Mohammed Ashab.
Yes, sir. Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you for the invitation for this great event. Thank you, Dr. Professor Gamal Hosni and Professor Mohammed Ashab. I will discuss the principle of CP management. CP is a non-progressive lesion as regards the brain, but as regards the musculoskeletal system, it is somehow progressive, because most common is a spasticity will lead to shortening and to contracture with a result of soft tissue and bony deformity, of course. We all know that it is upper motor neuron lesion, but it is not a purely motor disease. It is accompanied usually with a sensation loss,
Professor
concussion.
Mustafa, let me stop you here.
No?
I don't think we can see your screen. We're seeing Abdelal's screen yet.
Oh.
No, sir. I can see Professor Mustafa's screen.
It's very clear. I can see the screen also
Yeah, I
from my
can see it,
side.
sir.
Yeah, I still see Abdullah, Muhammad Abdullah.
Okay.
Uh,
Something.
I-
Dr. Muhammad, have you stopped sharing your screen? Because
Yes,
I
okay.
can see clearly the presentation of Professor Mustafa.
It's very clear.
I will try to share to look.
Okay.
Yeah, maybe then my side is playing up. Okay.
Okay.
So let me log out and log in. Please carry on. My apology for
Okay.
interruption.
No. It is not a purely motor because it's accompanied with association problem like sensation, cognition, perception, as well as communication and epilepsy as well. The upper motor neuron lesion, we know that it is most commonly will lead to spasticity, hypertonia, and hyperreflexia. And this spasticity will lead to secondary pathology like muscle contraction, joint deformity, and bony alignment. It's the old classification, which still about it depends on the anatomical or pattern classification, can be classified into bilateral and unilateral as well. Bilateral involved with diplegia, with the lower limb is more involved than the upper limb, and the total body involvement or tetraplegia or quadriplegia, which affect even the spine and the neck as well. And unilateral, which is the hemiplegia, as we all know. The pathophysiological classification depends on the site of lesion, and it's the most common is the spastic, which has a good prognosis than the dyskinesia and mixed type, which has a bad prognosis. But the gross motor function classification is important because it is the help in decision making of the management of CP because it as it is classifies the CP into ambulant and non-ambulant or ambulating and non-ambulating and classify is in level 1 and 2 and 3, which is ambulating, and level 4 and 5, which is non-ambulating. This can be co-opted with the anatomical classification, because the unilateral classification or unilateral CP is which is the hemiplegia. It is usually ambulating level 1 and 2 as regards the gross motor function classification. And the diplegia usually also ambulating level 1 and 2 and 3, while the quadriplegia is usually non-ambulating level 3 and 4 as regards the gross motor function classification system. The important gross motor function classification is it gives us an help in decision making, because the aim of treatment of CP is not the cure, of course. It is the aim of treatment of CP is to improve the quality of life. In ambulating patient, gross motor function 1 and 2 and 3, the aim of treatment is to correct the abnormal gait in order to move by the least energy expenditure. While the non-ambulating cases, the aim of treatment is to improve the quality of life by facilitating nursing and hygienic care and achieve comfortable setting. So as regards the ambulating, the important is to detect the abnormal gait. So we must analyze the gait to detect the abnormality. And by detecting the abnormal gait in the certain phase of gait and certain plane of gait, by certain examination, we can detect the cause of this abnormality. And by correcting this abnormality, we can improve the quality of gait, and we can improve the quality of life by improving the gait in the ambulating and by walking with the least energy expenditure. So the important in ambulating, analyze the gait and to detect the abnormal gait by analysis. We not mean that to get analysis the gait by 3D instrumented gait analysis, which is important if it is available. But we concern about the clinical gait analysis by observation and video. So the gait is simple, can be classified into stance and swing. The stance started by heel strike, mid stance, in which the knee is passively extended by the plantar flexion, knee extension coupling mechanism, and heel off and toe off. And the swing phase, it's important to make the foot clearance by marked flexion of the knee during the swing phase, of course. By analyzing the gait, we must clinically analyze systematically this to detect the abnormal gait in order to improve the quality of gait in ambulating patient. So we must examine the right side and then the left side. We must concentrate on the stance phase and then on the swing phase. We must concentrate in each phase in the frontal plane, sagittal plane, and the rotational plane as well. And each plane, we must start systematically, either from up, down, from the trunk to the foot, or from the foot to the trunk, to don't miss any abnormality in any plane. So if we start in the swing phase, the abnormal gait in the swing phase, which is a stiff knee gait. What is the stiff knee gait? Like this patient, he has the right stiff knee gait. He cannot do maximum flexion or foot clearance during the swing phase. And this is most commonly one of the important cause of this stiff knee gait is rectus femoris contraction. And by examining this rectus femoris by the Ellis test, so we can detect that the rectus femoris is the cause. And by doing just distal rectus femoris transfer or intermuscular recession of the rectus femoris, we can correct the abnormality of this gait and to get a good quality of gait and improve the quality of life of this patient, like this patient after rectus femoris distal transfer. In the stance phase, we must start systematically in the sagittal plane and detect the abnormality in this on the frontal plane and transverse plane. If we start by the sagittal plane, we can either get the equinus or jumping gait or apparent equinus or crouch gait or asymmetrical gait. This patient has a jumping gait with a flexed knee and equinus deformity. This equinus must be, to isolate the abnormality of this equinus, we must do a certain examination to clarify what is the cause of this equinus, to just correct the cause only and not overcorrect. And so we must do a self-vascular test to differentiate what is the cause of the equinus, either it is gastrocnemius per se or gastrosoleus. And if it is gastrocnemius, we must do just the gastrocnemius recession and not overcorrect by doing tendo Achilles lengthening, which will lead to crouch gait. And this patient has also adductor contracture, bilateral hamstring, and bilateral gastrocnemius, and this is after correction. So we must systematically examine the patient, and by detecting the abnormality in the gait in the certain phase, in the certain plane, and by certain examination, we can isolate the cause of this abnormality and just correct it per se, we can get the best, good result. Is another patient with a crouch gait. As we all know, it's the flexed market flexion of the knee and the dorsiflexion of the foot, and with walking with bilateral support. And by examination, usually the crouch gait is not a unilateral plane deformity, usually multiplanar deformity, including not only a flexion of the knee or causing of the knee, may be liver arm dysfunction like malrotation and valgus foot and flexion of the hip as well. And this is a patient, by examination, has a positive popliteal angle test, which means that it's a hamstring contraction. But in many cases, popliteal angle test like this can be a false positive if he has a flexion of the hip, because if he has a flexion of the hip, can cause marked anterior tilt of the pelvis, and this will cause a stretch of the hamstring before you test the hamstring by popliteal angle. So if there is a flexed hip when we do a popliteal angle test to detect the hamstring, we must do a double popliteal test like this to detect the hamstring shift if it is present by obliteration the lumbar lordosis if there is a hip flexion, and do a popliteal angle, and you can detect either if it is a truly hamstring contracture or it is a false positive popliteal test. In this patient has a truly hamstring contraction as well as iliopsoas contraction as well. And in crouch gait, there is a high moment or high power of the quadriceps during this walking to maintain this upright position. So this quadriceps contraction or quadriceps power can cause stress fracture of the patella, as we know, and this will be corrected by the correction of the crouch by single event multi-level surgery. And this patient has a bilateral iliopsoas, bilateral rectus, bilateral hamstring, bilateral fixed flexion, bilateral patella alta as well, and left external tibial torsion. And all of this must be corrected as a single event by two teams. And this one team do just by correction of the supracondylar by KY, and the other team by the other limb by the plate, and has the good correction, and after the correction, the stress fracture is already corrected by, and this is by supramalleolar due to have the patient has a left external tibial torsion as well. And this is after 4 years of correction. By examination the frontal plane, one of the deformity can be seen is a scissoring, which is one of the limb is coming over the other, and usually it is due to an adductor contraction. And one by examination to detect the cause of this adductor to get a scissoring, we must do a Philip test by making there is a limited abduction with a flexed knee, and this is surely due to adductor contraction. And so by making an X-ray, we can detect the percentage of subluxation or migration percentage, and according to this, we can decide the surgery. And this patient has a migration percentage within one side 42 and the other side 35. And by doing a simple adductor release, we can prevent more further, more severe operation and more progression of the deformity into dislocation by early diagnosis and early doing just a very simple operation. And this is after correction. As regards the transverse plane deformity, it is a rotational malrotation, either in touring or out touring, or even a compensated. I mean that the direction of the knee is not at the same direction of the foot, even if it is within the normal foot progression angle. We know that the in-touring, when the foot progression angle is inward more than 4 degrees, and out-touring if it is out more than 15 degree, but maybe within normal foot progression angle, and it still has a malrotation if it is the direction of the patella is not the same as the direction of the foot, because it is the combined deformity. By making a Staheli profile, we can detect, we must isolate the cause of this malrotation by applying the Staheli profile. and either this malrotation coming from above the knee or below the knee. I mean above the knee, like from the hip, either excessive anteversion or retroversion, and below the knee, which is either external tibial torsion, internal tibial torsion, or foot deformity. This is a patient has a kissing patella and with the in-toeing, and this is the type of walking. She walking with the in-toeing, and once the patella is inward with the foot inward, we can expect that she has an excessive anteversion. And by certain examinations like Sahili profile, we can detect, we sure that it is the cause of excessive anteversion without doing any X-ray further. And this patient has excessive increased internal rotation of the hip and limited external rotation, and which is ensuring that it has an excessive anteversion. And just by doing simple operation bilateral supracondylar derotation osteotomy, we can correct this abnormal gait and improve the gait quality and improve the quality of gait with the least energy expenditure, which is the aim of treatment in diplegia or ambulating CP.
يلا يا هند. ترجع تاني.
This patient has bilateral out-toeing, but at the same time he has a kissing patella. So by applying the Staheli profile, we can detect what is the cause of this malrotation of this abnormal gait. This is a patient has a crouch gait as well, with the malrotation, bilateral out-toeing, but at the same time has bilateral kissing patella. So we can expect that as a patient has malrotation combined both above the knee and below the knee as well, and must be sure by the Staheli profile. By examining, applying Staheli profile on this patient, he has an increased internal rotation of the hip and the limited external rotation, which is sure that it has excessive anteversion. And he has as well a foot side angle increase, but the patient has also a bilateral valgus feet. So we must make an examination or this test to decide if it has external tibial torsion as well with the valgus foot or not. So foot side angle per se is not enough. We must isolate the foot from the equation by making a transmalleolar axial axis angle, which is isolates the tibia from the foot to detect if it is has external tibial torsion or not. This is the foot side angle, and by making a transmalleolar axis and perpendicular line, and this perpendicular line over the transmalleolar axis, so we isolate the foot from the equation, so it is still has increased transmalleolar axis angle, so has an external tibial torsion as well. So must be corrected. So by making a single event multi-level surgery, we do in this patient bilateral adductor, bilateral hamstring, bilateral supracondylar derotation osteotomy for excessive anteversion, and bilateral supramalleolar derotation osteotomy for external tibial torsion, and bilateral triple C calcaneocuboid cuneiform osteotomy as well. So it is after correction. يلا بابا يلا بابا ايوه تعالى تاني تعالى تاني لف تاني ارجع تاني. As regards non-ambulating, improve the quality of life by making a comfortable setting, easily nursing, and usually the hip is the main problem because it can reach to 90% of the non-ambulating has a hip dysplasia. This patient has a right hip dislocation. We make this X-ray, and usually we do a CT to detect that it has a deficient in the posterior part of the acetabular, because it is in CP, it is usually posterior lateral dislocation. And in these cases, we do a varus rotation osteotomy as well as the modified Dega pelvic osteotomy as we present this in case to correct the deformity. The aim of treatment is to get a comfortable setting and easy nursing. The CP management is a teamwork. We cannot do it by yourself only. You must need a combination with the neuropediatric and physical and the physiotherapist as well. The operative is the only option if there is a fixed deformity. Spastic CP has the best prognosis, and the gross motor function level reflects the severity and help in decision making to improve the quality of life. In ambulating patients, they improve the quality of life by detecting the abnormal gait, and by improving this abnormal gait, we can move with the least energy expenditure. And in non-ambulating, by getting comfortable setting and nursing. In ambulating, we must, by clinical gait analysis, we can detect the abnormal gait, and by certain examination, we can decide what is the cause of the abnormality. Is it a spastic or contracture or compensatory? And so we must analyze the gait in each phase, stance phase and swing phase, and each plane, when usually the patient, the CP patient has a multi-level and multi-planar deformity, and by certain examination, we can detect the cause of this abnormality to be corrected per se. And by single event multivariate surgery can correct all the deformities simultaneously and prevent further compensatory deformity and limit psychosocial effect of multiple surgery. And by early mobilization and the strengthening of the muscle can reach the optimum result. We must not forget that we don't treat the CP patient just to correct improve the function and treat the symptom. We must be realistic in expectation, must be carefully articulated that, for example, in non-ambulating, we make a very big operation like spine fusion or hip varus rotation and pelvic osteotomy. In order to get a comfortable setting, we must discuss with the patient and parents what is the aim of the treatment. And we must respect the natural course, because the CP has a delayed milestones, but reach a plateau usually at the 7 years of age, and after that, which is the best time of operation to be done after this plateau. Thank you.
Thank you so much Professor مصطفى الشربيني على المحاضرة الشاملة الجامعة اللي نقدر نقول عليها CP from A to Z.
Thank you, Dr. Muhammad.
Thank you so much. If we have any questions to Professor Mustafa? At the end, I would like to thank all our speakers from all the Arab world, from Egypt and all the Arab world, Bahrain, United Arab Emirates, Iraq, Kuwait, all our, and UK, of course, all our guest speakers. Thank you so much for all of you for sharing your long experience in this very fruitful scientific day. ودكتور جمال حسني بس بيعتذر انه اضطر يسافر وهو رايح الامريكان اكاديمي، فهو دلوقتي في المطار، فهو بيعتذر لحضراتكم ان هو مش قادر ينهي اللقاء مع حضراتكم يا فندم. كل عام وحضراتكم جميعا بألف خير، وشاكرين افضل حضراتكم على تشريفكم معانا في اليوم الجميل ده يا فندم.
ماشي.
كل عام وانتم بخير وتصبحوا على خير.
كل سنه وحضراتكم
السلام
طيبين
عليكم
جميعا
ورحمة
يا
الله
رب.
وبركاته.
رمضان مبارك علينا جميعا يا رب. تقبل الله
آمين.
شكرا اساتذتنا الافاضل.
بارك الجميع. شكرا جزيلا. تصبحوا على خير.
وعلى خير.
السلام عليكم.
عليكم السلام.
السلام عليكم. ايه ايه قفلته ايه كان لسه شغال اهو. 2000 2000